and respected Professor Vasni Madam and my dear students. We welcome you all to one more interesting session of RISA DNB academic activities online. Today we have a case discussion on a Kyphoscoliosis case, followed by answer presentation by Dr. Sanjeev Raju from JRH on neonatal resuscitation. Without wasting much of your time, I hand over the session to Professor Rahul Sami sir and the students. Over to Professor sir.
Is the student ready? Venkateswar Rao? Dr. Venkateswar Rao?
Dr. Venkat?
I'm presenting a case of scoliosis for correction and anesthetic management, sir.
Okay, you are presenting. Have you ever anesthetized a patient or seen on patient?
Yes, sir. I anesthetized patient, sir, long back.
Very good. Okay, then it's good.
8 years back, sir.
8 years back.
Sir.
You are a post DA then?
Yes, sir. Post DA.
Okay, then it's no problem. Okay, go ahead.
Sir, here is a case of a 15-year-old girl, Shanti, residing at Ainavaram, studying 9th class, came with the chief complaint of deformity of the back for the past 2 years, sir. History of present illness. Girl was apparently all right 2 years back. Later, her mother noticed some deformity in the back, which is gradually progressing for the past 2 years. It is deviated to the right, extending from mid to lower thorax, with bending towards the right, sir.
Okay.
It's not associated with any pain or gait disturbances. The deformity does not disappear on bending or lying down position, sir. It persists in any position. She doesn't find any difficulty in sitting. She used to go to school regularly, used to play with her friends, and used to perform all outdoor activities. And there is no history of any breathlessness, dyspnea on exertion, and there is no history of frequent fever, cough, or wheezing, and there is no history of palpitation, syncopal attacks, and there is no history of pedal edema. And the patient also, there is no history of weakness of upper or lower extremities, and there is no difficulty in squatting or climbing up of stairs. And there is no history of any trauma to the back, sir.
Very good.
Past history, there are no similar complaints in the past, and the girl is not a known asthmatic, epileptic, or tuberculosis history. Birth and developmental history. Mother gives there is no history of delayed or prolonged labor during delivery of this child, and there is no history of delayed milestones, and there is no history of learning disabilities or autistic traits.
Okay.
Personal history. She attained menarche at the age of 12 years, and her cycles are regular. Family history. There are no similar complaints in his family or siblings, and there is no history of any consanguineous marriage in her family members. Treatment history. She has not undergone any surgery for any illness, and she is not allergic to any medications. This is the history, sir. Then general physical examination.
Any other important history you have to elicit in this case? Any other infection which can lead to this sort of deformity gradually? Any history?
Tuberculosis. I told.
You told about the family, but by this child,
past history, there is no history of asthmatic, epileptic, and tuberculosis.
Tuberculosis. Okay. Right. Any history of seizures at any time?
No, sir. No history of asthma, epilepsy, or
epilepsy.
tuberculosis.
Okay. Right. Tuberculosis and this thing. Right. Okay.
For general physical examination, girl is conscious.
Also, history is suggestive of muscular dystrophies.
Sir, ma'am, there is no history of upper and lower extremity.
Yeah, he has said that she is able to participate in all the games and
there's no history of any squatting or difficulty in squatting, climbing stairs, and no history of upper motor weakness.
Okay.
Yeah.
Right. Okay, go to the examination of the patient.
The girl is conscious, coherent, cooperative, oriented.
Hello?
Sir, girl is conscious, coherent, cooperative, oriented in time, place, and person. She is moderately built. Height is 150 centimeters. Weight is 50 kgs. BMI comes around 22. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and no pedal edema. Coming to vitals, sir, pulse rate 96 per minute, regular, normal volume, normal character, condition of vessel wall is normal, no radiofemoral delay, all peripheral pulses are felt. Blood pressure monitoring measured in right upper arm in sitting position comes around 106/72. Respiratory rate 16 per minute, regular, thoraco-abdominal. Temperature, she is afebrile to touch, sir. SpO2 98% on room air. Breath holding time is 25 seconds. Coming to the airway examination, mouth opening is more than 2 fingers. Mallampati class 2. Dentition is normal, no buck tooth. Thyromental distance more than 3 fingers. Upper lip bite test is 1. No high arched palate is present. Her neck flexion and extensions are normal, sir.
Very good.
Coming to the examination, spine examination, I inspected from the back. Curvature of the spine extending from mid-thoracic to lower thoracic. Appears to be expanded from mid-thoracic to lower thoracic. Side of convexity is towards right. Contour is smooth. Skin appears to be normal. No sinus scars. Level of the shoulder is asymmetrical with the left side at the lower level than the right. There is no excessive rib hump or no loin hump. There are no signs of hair or dimple above the natal cleft. And the inspection from side is there is no excessive lordosis and kyphosis, sir. Coming to system examination, respiratory system examination. Upper respiratory system appears to be normal. Lower respiratory system inspection, trachea appears to be shifted to mild to right. Chest wall shape is normal. Moves equally with respiration. No chest indrawing, scars, sinuses, engorged veins, and there is no axillary muscles of respiration. Axillary muscles of respiration are not active. Palpation, inspiratory findings are confirmed. Apex beat not palpable. There is no tenderness in chest wall. Chest expansion is normal. Tactile fremitus is equal on both the sides. Percussion, all areas, supraclavicular, infraclavicular, mammary, axillary, suprascapular, infrascapular, interscapular, all areas are bilateral, they are resonant. It's normal liver and cardiac dullness. Auscultation, air entry is equal on both the sides. All the pulmonary areas, vesicular breath sounds are heard, and there is no wheeze or crepitations. Coming to CVS examination, S1, S2 up normal in all areas, mitral, aortic, tricuspid, and pulmonary area and neoatic area, and there are no murmurs. CNS examination, higher intellectual functions are normal, motor and sensory system is normal, deep tendon reflexes are normal, and other system is normal, sir. My provisional diagnosis, 16 years old girl, right-sided thoracic flexible, late onset, probably idiopathic scoliosis with no respiratory CVS, neurological compromise, coming for scoliotic surgery correction, mostly for cosmetic reasons.
Okay. Did you get the case scenario given before the class?
Yes, sir. Night I got it.
Night you got. Can you, do you have it with you? Because it was specifically mentioned what is the Cobb's angle and there was a tilt in the shoulders. All these things were given in the case scenario.
Yes, sir.
Did you read that?
A Cobb's angle I read, sir, regarding the case.
No, the whole thing was given in 2 lines. 15-year-old girl noticing a progressive deformity of the back with the left shoulder getting tilted lower than the right shoulder and with a Cobb's angle of 60 degrees posted for scoliosis surgery. What is your anesthetic management? That is the wording given in the case scenario. So do you think Cobb's angle, if such measurements are given in the case scenario, do you think that it carries some importance or not?
Yes, sir. Important, sir.
Okay, if it is 60 degrees Cobb's angle, what is the importance?
The
Or what
respiratory,
do you expect what the patient to have? Do you expect them to have a normal respiratory cardiovascular functions?
60 to 7, more than 60 to 70 is respiratory compromise might be there.
Yeah, that's very important. Supposing it is a case scenario given with all these measurements already, then you have to expect all these changes. You can't expect to have a completely normal respiratory and cardiovascular functions in this patient. And
Okay.
definitely you said the chest wall appears normal both sides. Definitely with a 60-degree Cobb's angle, what do you expect to the rib cage and the thorax to happen?
But it will deviate, sir.
Which one
And
will
there
give? Is it called deviation? Deviation is for the vertebra.
rotational
Rotation is only for the vertebra. But what will happen to the rib cage?
Crowding, crowding of
crowding,
Ah,
crowding.
or it will get splayed on one side and crowded on the other side, isn't it? So which side will get splayed and which side will get crowded? The convexity side or the concavity side? You said there is a
convex,
convexity on the
Convex,
right, facing the
correct.
right, and concavity facing the left side, isn't it, in this case? So what do you expect the rib cage to, which position they will adopt in the convex side and what position will happen in the concave side?
On a convex side, there will be crowding will be there, sir.
Convex side, will it be crowding or it will be more, see, when it gets bent like that, what will happen to the ribs? Will they go apart or will they come together? See, the vertebral column is, if normal patient, it is straight with a slight backward bending. Kyphosis is there, isn't it? Thoracic region, you get normally a kyphosis. Lumbar region, a lordosis, that is forward bending. So any normal patient will have a small backward bending of the thoracic vertebrae. And the ribs are horizontally splayed at equal distance. Supposing the whole vertebra gets twisted and then bent to the one side, then the ribs, will they become wider or will they become closer?
Wider, sir.
Wider. So gets played on the convex side, and on the concave side they are supposed to come closer to each other, isn't it? So the chest wall cannot appear to be normal in cases with a 60-degree angle. Okay? So even though these are all imaginary case scenarios, your presentation should match that findings given. So you cannot have an absolutely normal chest wall in a patient with a 60-degree Cobb's angle. Okay. And another important history, when did the child start noticing or the parents start noticing the change in the shape or the deformity occurring? It is a progressive condition, isn't it? So the mother would have definitely noticed the child having a small bend early and then it is becoming progressive and going up to 60-degree Cobb's angle means it's a fairly very obvious bending or curvature. And with this curvature, is it impossible to have a normal scapula without the hump, isn't it? So these points you should have taken into account. If supposing the case scenario says it's only a bending with no values given of the Cobb's angle, then whatever you have presented is absolutely fine. But when there is a specific catch in the scenario by giving a measurement, then you have to think of, because there is a classification, isn't it? What will
Yes,
happen
sir.
if there is a 10-degree Cobb's angle? What will be the effect if it is 20? What will be the effect if it is 40, 60? Can you enumerate what are all the things that will happen depending upon the Cobb's angle?
Sir, if normally it is less than 10 degrees,
Yes.
if 25 degrees, there will be echogenic finding of increased pulmonary artery pressure.
So soon with 25 itself. Okay.
Echogenic finding of pulmonary artery pressure.
Okay.
More than 40 degrees, the
Hmm.
patient requires surgical correction.
No,
More
that is
than
about surgery indication, but what are all the changes that you expect in the normal
Sir.
anatomy and physiology of the patient?
So he can first tell us what is Cobb's angle, sir.
Cobb's angle. Ma'am, Cobb's
Okay,
angle,
Dr. Cox.
how to, first identify the uppermost vertebra of the curvature of the spine.
First of all, if they ask you a question, what is Cobb's angle? What should be your first answer?
The Cobb's angle is measured.
It's an X-ray calculation. It is not
X-ray.
calculated directly from the patient, isn't it?
Yes,
So
sir,
you
X-ray.
have to first have an X-ray of the patient in the erect posture, chest X-ray, and then will you take a AP view or a PA view?
AP view, sir.
AP view. Why do you want to take an AP view?
To know the bony prominences.
Yes, then only you get the vertebra delineated nicely. Okay, if you take a PA view, you will get only the heart and lung shadows better, and the vertebral shadows will not be normal. So you have to take a AP view of the chest, and then you have to measure the bending maximum where it starts and then where it ends. The topmost vertebra where you said the scoliosis is confined only to the thoracic region. Okay, where else it can occur? How can you classify the scoliosis? What are all the methods of classifying scoliosis?
Classifying
Classification of scoliosis.
cervical, lumbar, sir.
Based on the location, it can be cervical, it can be cervicothoracic, it can be thoracic, or it can be thoracolumbar. Okay? So based on the location of the curvature, it can be classified as cervical, cervicothoracic, thoracothoracic alone, thoracolumbar. These are the 4 areas where it will happen. Is there any other classification?
Based on cause,
Etiology. Okay,
Etiology.
so based on the etiology. Second classification is based on the etiology, whether it is idiopathic, whether it is acquired, under acquired, whether it is traumatic, infectious, neurological, musculoskeletal. Okay, so many classifications are there. So there are 2 broad classifications. One is based on the location of the curvature. Second is based on the etiology. Now, this is purely a thoracic. What you have described is a purely thoracic scoliosis. So, Cobb's angle is a X-ray finding. It's measured using a X-ray chest of the patient, AP view, and you take draw a line from the upper border of the top vertebra where the curvature starts and the lower border of the vertebra where the curvature ends. And then made them meet at an angle, isn't it? Both of them will cut each other and make an angle. Is that the Cobb's angle? When
Yes,
you
sir,
draw
Cobb's.
these 2 lines and then at the point where they meet and form an angle, is it called the Cobb's angle?
Yes, sir, Cobb's angle. Where perpendicular line drawn from 2 parallel lines, sir. First
Okay.
parallel line is drawn from the upper border of the uppermost vertebra where the curvature starts. Second line is drawn from the lower border of the lower vertebra where the curvature ends. So draw a perpendicular line from the upper and the lower parallel lines where they get intersect. It comes the Cobb's angle.
Okay. Can't you measure it from the first line which you draw alone?
No, sir.
No?
First line, parallel line.
No. One you have to drop one perpendicular line from the first line you draw, and then they both intersect. That is also Cobb's angle. If you draw the line straight and then you
If you draw and intersect, where they intersect, it also comes under Cobb's angle.
that also is a Cobb's angle. Okay. So either way you can measure. Okay. So this is called the intersection angle. That is called symmetrical angle. So both of them will have the same value, and that is what is called Cobb's angle. Okay. And who described this? Who is the person? Why it is called Cobb's angle?
I don't know. Cobb.
Lippmann Cobb
Cobb.
described.
Huh?
Cobb's.
Lippmann Cobb described.
Littman Cobb. Who is Littman Cobb? His name is not Littman Cobb. His name is John Robert Cobb, who was an American orthopedic surgeon who described this first. Okay, way back in 1930, he described that. John Robert Cobb, American orthopedic surgeon, was the person who was responsible for describing this Cobb angle. So, what is the maximum angle you can get?
120 degree
120
maximum.
degrees. Yes, 120 degree has been the maximum. So in 120 degree, what will you have? If a person has got that much of gross scoliosis of 120 degrees Cobb angle, what will happen to the patient?
Sir, alveolar hypoventilation, chronic
You will develop alveolar hyperventilation and chronic hypoxemia. And chronic hypoxemia will lead to
pulmonary artery hypertension,
pulmonary
right
artery hypertension, right ventricular failure.
ventricular failure, carpulmonary.
Very good. So there are different degrees. So when the degree is mentioned in the case scenario, you have to present the case in such a way, expecting the changes that would normally take place with that particular Cobb's angle. It cannot be completely normal like what you have described. Okay?
Okay.
Right. So if supposing this, you take this 60 degree into account, what
Yes.
changes you expect in the respiratory system and what changes you expect in the cardiovascular system? And
Sir,
what
it is the
changes in the neurological? These are the three important systems which can be affected by a scoliosis. More than cosmetic purpose, functionally, these three systems will be affected for which you require surgery. Okay? It is not only for cosmetic correction, but also for functional disability. So can you enumerate the changes that will take place in the respiratory, cardiovascular and neurological systems and why they happen if there is a curvature like this?
Sir, it is a restrictive lung disease.
Mm,
So whenever the Cobb's angle increases, the
Mm.
thoracic cavity size will be reduced,
mm,
and the patient find difficulty in breathing, and
mm,
work of breathing will be increased.
mm,
Can lead to ventilation perfusion mismatch,
mm.
and
Excellent. Very good. Go
and,
ahead.
the, and if it progresses, the
Mm.
patient may develop dyspnea on exertion clinically,
Mm,
and still it progresses, chronic hypoxia
mm,
and ventilation is impaired, chronic hypercarbia,
mm,
which can lead to increased pulmonary vascular resistance,
mm,
and which can lead to right ventricular hypertrophy, leading to failure,
mm,
finally leading to carpulmonary.
mm.
Sir.
Okay.
So it also causes mechanical impingement of the heart, reducing the cardiac output
Mm.
due to the deviation.
Very good. So now can you explain why I asked you about when the deformity was first noticed and what was the rate of progression? At what age did the mother or the parent notice the deformity? Is it a very valid question or not?
Yes, sir, if it is less than 80 years,
Ah,
pulmonary system development will be impaired, sir. Alveolar, number of alveolar
development. Very good. So
development
hmm. So
will
the
be
number
impaired.
of alveoli growing will be taking place up to the age of 8 years. Okay. So if
Sir.
the disease has started right less than 8 years, say from the age of 6 years itself, gradually it has been going on, and patients notice only when it became very gross. Then there is a possibility that the developmental increase in the number of alveoli will be decreased, which will also add up to this problem, isn't it? So that is a very important history that you should ask whether the parents or the mother noticed a small change. You know, very observant mothers will know that, yes, sir, at the age of 5 or 6 itself, whenever I was bathing the child or making her dress up, I noticed that some problem is there in the back, but I ignored it. Or I did not think it was a very important thing. So it has been there for quite some time. That history is very, very important. Then definitely with a 60-degree angle, they will have more problem with the respiratory system and cardiovascular system. What are the neurological affections that can happen if the angulation is more than 60 degrees?
Sir, it may compress the spinal cord,
Mm,
sometimes compress
mm,
the spinal cord,
mm,
and may have weaknesses,
mm.
sensory disturbance, sir.
Sensory or motor deficits can happen in the lower limb. And can there be a disparity in the length of the lower limb?
Sir,
For
it's a
example, hmm,
non-structural scoliosis.
what do you mean by non-structural scoliosis?
Sir, scoliosis, which is due to both the limbs disparity, lower limbs disparity,
Hmm.
which can be flexible and can be corrected by bending or lying down. They can be corrected by certain postures. That is the non-structural. Structural, they cannot be corrected by bending or any other postures, and they are concerned with lower limb disparities.
So did you ask the patient whether they had any, you said there's no tilt or balancing, difficulty in balancing. Walking gait was normal.
Gait is normal, sir.
So, but 60 degrees, do you expect the child to have a normal gait?
With 60 degrees, no, sir.
Yeah, that should. So these are all the points that that will come up. If the angulation is given, if the Cobb's angle is given in the history, then you have to think in terms of what are all the musculoskeletal deformities that will accompany this particular thing. There will be definitely a hump in the back because of the raised scapula. There will be some distance narrowing between the rib cage and the pelvic girdle. So there will be one side it will be broader and other side will be narrower, and that will lead to pulling of one limb, and the child may have disparity in the length of the lower limbs also. Okay, so all these things have to be described in such a way that you cannot ignore that 60-degree angle and then describe everything as to be completely normal. Okay, that is the catch in that question. That is the specific reason why the Cobb angle measurement also was mentioned in the case scenario. Okay, so you cannot ignore and then just describe as though it is a milder variety of scoliosis with all the systems being normal. Okay, right. Now, from now on, we will proceed with the case scenario as it is given. So with the 60-degree Cobb angle indicating definitive surgery is needed. Now, how will you proceed to investigate, optimize, and give anesthesia for this child, and what are all the challenges you will face?
Sir, starting
First
with
thing, investigation.
investigations, complete bed picture, coagulation profile.
What do you want to see in the blood picture, and what is the purpose of doing? Every investigation, you should describe why you want that, and then what are the other additional things in this with relevant to this case you will utilize that for.
The total leukocyte count, sir, to rule out any infection.
Okay.
Hemoglobin, hemoglobin and platelet count.
What is the importance of hemoglobin in this case?
Sir, it is a major surgery, and there will be more blood loss.
Okay.
And most of the patients are anemic. Some of the
patients are anemic. Is that supposing
nutrition will be lesser?
Why should there be anemic? Why should there be anemia? There's nothing. There's no. I don't think there's any correlation. Anemia and kyphoscoliosis.
Any other importance of hemoglobin? Supposing this girl has got a hemoglobin of 15 grams per deciliter.
Sir.
What can you do with that? Would you be very happy, or you can utilize it for some other purpose?
Polycythemia is due to chronic hypoxia.
Autologous blood transfusion plan.
Autologous transfusion. For that
we can plan, sir. Autologous blood donation we can plan.
Okay, pre-operative autologous blood donation, PABD. Okay, one then, or supposing that is not possible, there is no facility for that. What is the next method of autologous transfusion?
Cell salvage technique.
Cell salvage after starting the surgery. So there are three things you have to remember. See, autologous blood transfusion means transfusing the patient's own blood back to the patient. That is the meaning of autologous transfusion. Okay. So if the hemoglobin of the patient is quite good, and if they don't have any other, it is not abnormal or pathological, as somebody said, hypoxemia producing polycythemia, that this increase or the normal hemoglobin can be utilized in three ways. One is to please wait. One is to donate the blood pre-operatively. Second is to donate the blood on the day of surgery. Third is to collect the blood and wash it and retransfuse it on the day during the surgery. These are the three timings at which you can do that. You can collect the blood pre-operatively. What is the time interval between which you can collect and then use it on the day of surgery? That is pre-operative autologous blood donation. When can it be done?
4 to 5 weeks, sir.
Not 4 to 5 weeks. That is too long a period.
Yes.
It should be started with at least just 2 weeks prior to that, and you can collect maximum 3 times at the intervals of 4 days. Okay, so 2 weeks means 14 days. So every 4th day you can collect. But what else you should do? Can you just like that keep on collecting the blood from the patient?
No, we should supplement, sir, with
Erythropoietin.
Iron,
Erythropoietin.
folic.
Yeah, you can stimulate the production of RBCs by erythropoietin as well as nutritional supplement in the form of iron and folic acid, and then draw 350 ml of blood for each time, and then store it, preserve it for the usage during surgery. This is called preoperative autologous blood donation, PABD. Second method is on the day of surgery, you can draw out 350 to 500 ml of blood before starting the surgery and then replace that with what?
The crystalloid.
Crystalloid,
Colloid-
how much?
Colloids are crystalloids.
How
Colloid
much?
is
How much
1
is?
is to 1.
Uh,
Crystalloid is 1 is to
crystalloid
3.
1 is to 3. Okay, so you can replace the volume by these two fluids, either crystalloid 3 liters or 1 is to 3 ratio or colloid 1 is to 1 ratio on the day of surgery. This is called acute normovolemic hemodilution. This is not called donation, it is a dilution technique. The third method is to collect, pardon?
What's the precaution that you take when you use colloids for this procedure?
Madam is asking what precaution you should take if you are going to use colloid for replacement of the blood you draw.
To prevent volume overloads.
Volume overload. You are drawing out the blood and then only you are giving. Why should you do 1 is to 1 ratio? How will you cause that much of volume overload?
Too much of over dilution.
Which colloid you have to avoid? Which can interfere with something?
Starch, sir.
Starch will not. Dextran is notorious for
Coagulation.
that. Then dextran 80. That is, it will interfere with the
Blood grouping.
cross matching. Yeah, cross matching, not grouping. It will interfere with the cross matching and give a false reading. So you have to avoid dextran and then go for either albumin or you can go for diethyl starch also. Then the third method is cell salvage, which you collect the blood from the surgical field, wash it and rinse it, and then retransfuse to the patient according to the need. So these are the 3 methods which will be commonly asked in the examination, both in theory paper as well as in your viva. They can ask you about this, for which you must have a clear concept. So autologous blood transfusion is the heading. That is retransfusing the patient's own blood. That is collected either pre-operatively or on the day of surgery or intra-operatively during the surgery from the surgical field. These are the 3 methods of collecting and transfusing the patient's own blood, right? So the testing of hemoglobin is very, very important to decide about this, whether you can do this pre-operative donation or intraoperative acute normovolemic dilution. Okay, right. Then what are the other investigations you want to do?
PFT, sir.
PFT. Okay. What do you expect to see in the PFT?
Sir, FE1 by FPC ratio may be normal or increased.
Normal or increased. But TLC will be?
Reduce it, sir.
Without TLC, there is no point in just doing FEV1 to FEC ratio because you want to establish that it is going to produce a restrictive nature of the disease, isn't it? So flow volume loop and both the total lung capacity measurement and FEV1 FEC ratio, if all 3 are done, then only you can establish the diagnosis of restrictive lung disease, right? So FEV1 to FEC ratio will be normal or as you said, slightly increase, which rules out obstruction, but total lung capacity will be decreased. Supposing you have facilities for measuring the residual volume, what will happen to that? in a case of severe scoliosis like this, 60 degrees and above? Will the alveoli
No,
rest RV?
sir, no change.
RV will increase because they cannot empty completely. So the RV is slightly supposed to increase compared to the TLC. Okay. So this will be the picture that you will get. And if you draw a flow volume loop, how will you draw a flow volume loop for restrictive lung disease? Now you have committed about PFT, you must be able to answer these things. Restrictive lung disease flow volume loop is nothing but a miniature form of the normal flow volume loop. Okay. Both the respiratory, it's a miniature or a smaller version of the normal volume
Reduced.
loop. They are all reduced means smaller. The whole volume loop is smaller. It's like a baby of the normal curvature or the graph of the flow volume loop. Okay. Right. So PFT we want to do. Then what else? What other investigations you would like to do?
Routine investigations, blood urea, serum creatinine, serum electrolytes, blood grouping and cross-matching, ABG.
Okay. Now that you have started with the investigations pertaining to this particular clinical scenario, you started with blood grouping where we mentioned about hemoglobin as an important component. Then you said PFT to find out about the severity of restrictive lung disease. In continuation of that, would you like to do some other investigation which is more relevant to this particular condition rather than going in for the routine pre-op investigation of renal function, liver function, coagulation profile, all these things?
Chest X-ray, sir.
Chest X-ray, okay. Chest X-ray, what will it show?
Sir, site and severity, number of segments involved.
Will you be able to find out all that from the number of segments of vertebra? Okay, but chest X-ray will show you a gross rib cage anatomy, isn't it? As I told you, which side is more splayed and which side is more crowded, which lung is likely to expand better, which likely is not likely to expand. That may be seen, and whether there is a cardiac impingement, whether there is a dilatation of the cardiac shadow, any reactive pericardial effusion is present or not. All those things can be found out by X-ray. More than that, you said about pulmonary hypertension, which is a very important complication of restrictive lung disease. So how will you find out that?
Sir, 2D echo.
Echo. So you must
Echo has
always
to be done.
mention about the echo. Okay, so echo is very, very important to find out the pulmonary pressures, right ventricular outflow tract function, and the overall left ventricular function also is to be measured. Okay, so echo forms a very important investigation in this grossly bent scoliotic patients. Okay, any importance to be given to ECG?
RVH, if they are
RVH, yeah, you have to see for presence of RVH. How will you find out the presence of RVH using ECG?
Sir, in V1, V2, R wave more than.
Normally R wave will be very small in V1 and V2. If you find a tall R wave in V1 and V2 more than 5 millimeter small squares, then it is of significance to indicate that it is a right ventricular hypertrophy. Okay. So all the students this is a very basic knowledge that all of us should possess to identify RVH from a regular ECG. So these 4 investigations, namely the blood investigation, especially hemoglobin, then with the PFT, then echo, then ECG are very important to find out the respiratory and cardiovascular complications if they have occurred because of the very high degree of Cobb angle. Then all the other investigations like what you mentioned are all routine for any surgery. And of course, coagulation profile also you have to make sure and plan for any pre-operative blood donation, whether it can be possible to store the blood can also be decided at this stage itself. Okay, right. So having done all the investigations, how are you going to give anesthesia for this?
Sir, in the investigations, Sir,
Mm.
sir,
Mm.
in the investigations, they also mentioned to talk about suspecting malignant hyperpyrexia, especially in patients with the
That will be in the history itself. Supposing there is a weakness in the muscle, or if there is any family history, whether any relative has suddenly died or had developed a complication after general anesthesia, then that will be definitely valid. So on the back of the mind, you should keep the congenital problem of any muscular dystrophies or malignant hypertension, which is quite, even though rare, you have to keep in your agenda of examination. Okay. Right. Supposing there is a history of suggestive of malignant hyperthermia in the family, some relative has died after having developing high fever after the surgery or in the operation. How will you then? What will you do in such cases? Supposing there is a positive history for complication having had in the family because of which looks like a malignant hyperthermia. What precautions you will take?
Avoid scoling intraoperatively.
Okay.
And inhalational agents.
Yeah, very good.
Inhalational agents.
You must tell me practically what you will do. Supposing you are the anesthetist and you get this patient, 15-year-old girl, whose family says that somebody else in the family had an operation and the doctors told that patient developed high fever intraoperatively and collapsed. If that is the history suggestive of malignant hyperthermia, what anesthetic agents you will use rather than avoid? How will you anesthetize this patient? You say you will avoid scoline and volatile anesthetic agent, but you must also know what are all the agents you will use to perform a safe anesthesia for that and what other preparation you will do. If you know that there is a history of malignant hyperthermia in the family. You can use propofol safely. You can use fentanyl safely.
Induction can.
Can you use etomidate safely? Can you use ketamine safely? All these agents can be used safely. Okay, so you can go for propofol induction. You can use fentanyl. You can use ketamine if you want for analgesia. Okay, avoid totally all the inhalation agents and go for total intravenous anesthesia with midazolam and propofol infusion. And also keep one important drug ready in case, in spite of all these preparations, something goes wrong. Dantrolene sodium should be available. Okay, this is how you should plan. Once you get a question in the exam like this thinking should come automatically. Even for your practice, this is the way you have to plan your anesthesia. Supposing tomorrow by chance you get a case where they say family history of malignant hyperthermia is positive, then you have to think already before starting the case, what are all the drugs you can safely use and how are you going to give the anesthesia. And in spite of all these things, if it happened, dantrolene should be available. You cannot say, I thought with the use of propofol and fentanyl, I won't get this. Suddenly, even without using scoline, without using any volatile, some trace volatile being there, you must in fact empty the vaporizer completely and then flush the whole system so that there is no trace of volatile at all. Unfortunately, somebody else has done a case and you go and do the case. Some trace element of volatile is left in the circuit. That can trigger malignant hyperthermia, isn't it? So you must make sure that you use a new circuit. There is no volatile filled up in the vaporizer, or even the vaporizer can be totally removed, and you use only oxygen air mixture with a planning for TIVA with the TCI pump should all be thought of. And in addition to that, the additional security is in case something goes wrong, dantrolene should be immediately available. Okay, so this is how you plan the safe anesthesia for such patients. Okay. Right, so these are the 4 important investigations that you want to do. Any pre-op optimization you would like to do for this case?
Yes, sir. Advise the deep breathing exercise and incentive spirometry.
Excellent, excellent, very good. Okay, that is very important. Then what about the pain management? What are you going to tell the patient?
It's a complicated surgery, multimodal analgesia technique followed.
Mm.
Multimodal, starting with IV.
So good
analgesia.
counseling should be done to the patient. Okay, so patient should be mentally prepared for all the
Until
post-operative. So you must
complication.
talk to the patient and tell them what is going to happen, how you expect the whole thing to go through, and then make them become cooperative so that they can mobilize early and then breathe nicely in the post-operative time without any problem. Okay, right. After having done the optimization, what is your, how do you said you have already given anesthesia for this such cases. So how do you anesthetize? Tell me the practical steps in the anesthesia of this patient. Patient is already starved nicely, preoperatively, being an elective surgery. 6 hours of starvation is there. Any pre-medication you want to give?
Sir, sedatives and antiemetics. Alprazolam, ondansetron.
Ondansetron you want to give as a tablet, orally or parenterally?
Orally, sir.
Orally. So orally, you normally give ondansetron oral before surgery, or would you prefer to give it intravenous at the time of induction or extubation?
At the time of extubation.
Okay, so ondansetron is not necessary as a oral pre-medicant, right? Or is that the way you have been practicing ondansetron also orally? Whatever protocol you are used to, that you can say there is no harm in that. So that's not going to lose or make
we are not
I don't think anybody gives oral ondansetron. It's definitely
So
given. It's not. It's the oral ondansetron கொடுத்து ரொம்ப வருஷம் ஆச்சு sir.
That's all right. I don't think people normally you give anxiolytic like alprazolam or lorazepam, and then you give a proton pump inhibitor or a H2 receptor blocker. These are the two drugs which are given orally. So pantoprazole tablets or ranitidine tablet along with alprazolam preoperative night. It is not even given on the day of surgery. It is given the preoperative night to make the patient feel comfortable and calm so that they don't become anxious. Okay, right. So that is the pre-medication. Starvation is done. Patient has come to the OT. She is very cheerful and bubbly. Will she be able to lie down flat on her back if she has got a cob angle of 60?
No, sir. Difficult to lie on the back.
So that will be very little challenging, isn't it? Right.
Very challenging.
So now tell me what are all the steps of from starting the IV line. Tell me all the steps of anesthetizing this patient one by one.
Sir, first confirming the patient and shifting the patient to the
Very
and
good.
checking. First, I will confirm the patient, sir, whether the patient is right.
Yeah. Very good. I said very good. That's a very good habit. Make sure that you give the anesthesia to the right patient. Okay. And
sir, check the circuits.
Okay.
And everything is ready. Laryngoscope, different plates.
Very good.
And different airway kit. Everything is ready.
Very good.
And shift the patient inside. And start a IV line, sir.
Place the patient on the operating table.
No, stretcher, sir.
That's a very important step in this surgery. Normally, every patient is brought inside the OT and immediately transferred to the OT table, operating table, isn't it? Whereas for scoliosis or any spine surgery, we keep the patient in the stretcher trolley and then only induce anesthesia. For those who have not had the experience of anesthetizing a patient for spine surgery, this is a very important step that you have to remember. Otherwise, the OT technicians normally will immediately shift the patient to the OT table unless they are also very experienced. So this is a very important point for those postgraduates who are primary candidates who have not had an opportunity to see a spine surgery. Any spine procedure in the prone position, patients are induced anesthesia only in the stretcher trolley, not on the operating table. Then they are shifted face down to the operating table. That is a very, very important step. So what are the drawbacks or disadvantages in inducing anesthesia in the stretcher trolley. What are all the things you should check in the trolley?
Sir, it's trolley is moving or not.
Trolley
Okay.
usually can be mobile, isn't it? So how do
Mobile,
you
sir.
make it stable?
You should lock it.
Locking
Yeah,
system.
you must lock the trolley. Very, very important. Otherwise, as you are trying to intubate, the trolley will keep on moving and you will have to chase the trachea. Okay, you won't be able to intubate. So make sure that you can lock the trolley, and or somebody, if there some trolleys may not have a lock, they will be mobile all the time. So somebody should stand at the foot end and give counter pressure when you try to intubate. Okay, that is a very, very important basic step for practical purposes. Right. Then you start an IV line. Where do you start the IV line?
Sir,
Can I start in the elbow?
no, sir. Right upper arm, dorsum of the hand, preferably.
Dorsum, as peripherally as possible. Okay. So usually we start only on the dorsum. Never go for the forearm or the elbow because that will all be bent. So better to go as distally as possible in the upper limb where it can be undisturbed, and second, it is easy to reach also. So you choose the vein on the dorsum of the hand and then cannulate it and then connect it to your IV solution. What about the monitors? Where will you place the monitors?
ECG posteriorly, sir, on the back.
Now itself, will you place it on the posterior, or you wait for the patient to be turned? And what are all the monitors you can apply when the patient is on the stretcher trolley, and what are all the monitors you will apply after the positioning the patient?
Sir, SpO2, ECG, NIBP, NIBP.
Normally, what I do is I apply only the BP and the SpO2 probe. Okay. Because ECG I will usually place only after turning the patient, unless the patient has a history of any cardiac ailment like previous myocardial ischemia or anything. Normally, for a healthy patient, I don't apply the ECG electrode before induction. Because once you put it in the front of the chest, that will have to be removed, and then while you turn the patient. Otherwise, you'll have to put it on the limbs, the shoulders and the hip. So it may be a little clumsy. So my practice is to use only the BP, non-invasive blood pressure, and the SpO2, and then start the case after recording the basal parameters. Right, go ahead. Whatever you did, you tell me. Whatever you have learned earlier.
Connect the IV fluid, monitor, and pre-medicate the patient. Injection midazolam.
Would you like any other monitor? Would you like any other monitor while the patient is supine?
Sir, ma'am?
Would you like any other monitor while the patient is supine? Would you like to put in a urinary catheter?
Urinary catheter, ma'am.
It has to be.
Usually then after induction
After induction, we'll start the urinary catheter.
Do it after induction. Okay.
Before turning the patient,
patient is conscious, so we do after induction.
Okay.
So pre-medicate the patient at least 3 minutes before inducing the patient. So once the heart rate and people settles, deoxygenate the patient for 3 to 5 minutes, and start an IV induction agent, propofol, 2 milligram, keeping a hand on your pulse during induction, slow IV induction, and look for corneal reflexes and swaying of the limb, so that until sleeping dose of induction agent is achieved. So by check for bilateral, once the patient is unconscious, apneic, check for bilateral air entry. If able to ventilate, go with a non-depolarizing muscle relaxant. I'll choose atracurium, 0.05 mg per kg body weight, and give atracurium and ventilate for 4 minutes. And apply for jaw thrust. If there is no movement, it indicates that the patient is adequately paralyzed. So choose a correct size, preferably 7 size ET tube, endotracheal tube. After
tube would you choose? What tube would you choose?
The flexometallic tube, ma'am.
Now, one more question. before you plan this sort of induction, intubation, and anesthesia, should you discuss something with the surgeon?
Wake up test, sir.
Wake up test one, very good. Anything else? Nowadays,
Okay.
wake up test is not commonly done. We will come to that later. But some other method of monitoring is
Neuromuscular
Yeah,
monitoring.
neuromuscular
Neuromus-
monitoring.
Is it called neuromuscular monitor?
Neurophysiological monitoring.
Evoke potential monitoring. It is called evoke potential monitoring. Supposing surgeon plans to do an evoke potential monitoring, how will you change your anesthetic plan?
Shall I go with TIVA, sir?
TIVA. So how will you equip yourself for TIVA? What are all the drugs you want to use? What is the method? Have you ever done a TIVA with a evoke potential monitoring intraoperatively?
Yes, sir. I did, sir.
You have done. So you must be able to
Opioid,
tell me.
opioid and propofol infusion,
Ah.
100 to 200 mics per kg per minute,
Mm.
and dexmedetomidine infusion.
Mm.
And if the surgeon is planning for sensory evoked potential, somatosensory, I'll keep MAC around 0.5 to 1.
Mm.
If the surgeon is planning for motor evoked potential, I'll keep for 0.25 to 5. But better to avoid as a whole the inhalational agents, which can interfere with the readings.
Okay.
So I'll keep propofol, dexmedetomidine, and opioids.
But what about the ventilation? Are you going to control or leave it on spontaneous? Will you be using neuromuscular blocking agents?
I'm not using neuromuscular blocking agents.
So how do you adjust the ventilation? Patient will start breathing.
Yes, sir.
So how to manage that?
Sir, with low dose, low dose of inhalational agents, opioids, dexmedetomidine, and propofol infusion, sir. Titrating the doses.
Yeah, that is for maintaining the unconsciousness. My question is, patient will get back the motor power and start breathing, isn't it? So how are you going to manage the patient's spontaneous respiration? What is your method of ventilating this patient?
Sir, increasing the rate, sir, respiratory rate.
Either hand ventilate with spontaneous mode or SIME modes.
Pressure support ventilation can be done with the patient's breathing. That is a very important step. Whenever you plan for TIVA, you must adjust your ventilation in such a way that the patient does not fight with your ventilator, isn't it? So either you must, if supposing you want to be safe, you can synchronize your own manual ventilation with the patient's respiratory effort, or you can use pressure support, or as you said, SIMV also synchronize intermittent mandatory ventilation and make the patient, because usage of muscle relaxant will interfere with the motor evoked potentials. You will not get the proper response. Okay. So these are the things that you have to discuss with the surgeon. If he's not planning to use any intraoperative neurological monitors for the continuity or integrity of the nervous system, then you can use your regular conventional method of paralysis and control ventilation with the volatile agent, all these things. But nowadays, most of the spine surgeons prefer to use the evoke potential monitoring. Then it becomes a problem that you have to go only for TIVA with either a pressure support or a SIME method of ventilation for the patient, avoiding both neuromuscular blocking agents and your volatile anesthetic agents. This is a very important point you have to keep in mind and discuss with the surgeon. Right. So you have taken the induction agent, you have given the induction agent, you have paralyzed the patient, you are intubated with a flexometallic tube. Which side you will fix the plaster? How will you fix the plaster for the flexometallic tube? What are all the methods of fixing the plaster or securing the tube with a plaster? Normally, what do you do? How do you fix the plaster?
Maxilla to maxilla and mandible to mandible.
Maxilla, two plasters you put, maxilla to maxilla. That is, why you want to fix it to the maxilla?
Bony prominence.
Bony prominence or immobile?
Or immobility.
Maxilla is immobile. So always better to fix it to the maxilla. Whereas mandible is mobile structure. It can move, isn't it? So if the patient, especially with the spontaneous breathing, their jaw can sometimes move. And another thing is you must fix it in the area where it will be uppermost. Supposing you are going to turn the head to one side after positioning the patient prone, the
Secretions.
drooling of saliva will loosen the plaster and there is a possibility of slippage of that tube. That is the reason why I asked this question. Okay. So you have to plan all these things well in advance, that you fix the plaster in such a way that it doesn't become drenched in the saliva and become loosened, and the chances of tube slipping out should be avoided. Every care should be taken to make sure that the tube is in proper position all the time till the end of surgery. Okay, right. So you have intubated successfully, fixed the tube properly. Then what is the method of positioning the patient in prone? How do you do that? What are all the precautions you have to take while turning the patient?
Sir, before shifting, 100% oxygen should be ventilated.
Okay, before that,
Bilateral air
uh,
entry should be checked.
bilateral air entry you routinely check. But what other important observation you should make sure after induction, especially? Supposing you are after induction, the BP from 120/80
Fall
has
in
come
BP.
to,
Fall in BP.
if the BP has come to 80/40, will you shift the patient?
So preload
That's a very important practical point. Make sure that the patient is hemodynamically stable after an IV induction. That is very, very important because of before shifting the patient, if supposing you have not observed what is the blood pressure, there is a possibility patient can crash. Okay, so always make sure that the make a reading, see that the blood pressure is stable after induction, because propofol has got the tendency to cause a fall in blood pressure, isn't it? So make sure that the blood pressure is normal, and then if that is low, rush some fluid, make sure that it is come back to normal, and then allow the patient to be shifted. Do not allow them to. Some surgeons may be in a hurry. As soon as you put in the tube, they will say, come on, we'll make the patient prone. Don't allow that. Take always a reading after induction and intubation. Make sure that the blood pressure is stable, and then how will you secure the IV cannula? Will you shift it with the connected IV set, or normally how do you do that? Huh? You have to disconnect and close the cannula and make sure. Don't even have the extension if you have it, because sometimes, while shifting, the extension tube gets tangled and then the whole cannula will come out. So make sure that the cannula alone is there in place, and put a stopper and disconnect the whole IV set and the extension tubing if you are using it, and then make sure, tell everyone to take care of the IV line, and then disconnect the BP cuff and remove the pulse oximeter, and then turn the patient. Okay, that is the method that you have to do. And then
check for bilateral air entry, sir.
Air entry, before
After
that you have to
position.
properly position the patient. So that positioning, your anesthetist should know how to position the patient. What are all the things that are needed to position the patient in prone?
Sir, for eyes, you support, sir, high for eyes.
What are all the special
The
equipment
operating
that are
table, you
used?
prepared the operating table, no?
What are all the
Bolsters.
special bolsters can be used, or is there any specialized equipment that is available for positioning the patient? There are metal frames called Wilson's frame, Canara's frame, so many things are there. But what is the main important precaution you should take while positioning the patient in prone position? What is the most important?
Abdominal pressure.
Abdomen should be free to move. Okay, it should not be touching the operating table. So patient's abdomen should be free to move for a free diaphragmatic excursion. So patients are mainly supported in the pectoral region and the pelvic region. These are the two areas where you give the support. So if you give a bolster, it will support the entire upper thorax, and it will support the pelvis. Whereas if you use the specialized frames which are available, they will be placed in the right and left pectoral region and the right and left iliac crest region. These are all the areas where it should be placed. And you should be able to insert your hand between the abdomen and the table. There should be enough space between the table surface and the patient's abdomen. That is very, very important. And what other precaution you should take?
Gel foam head ring, sir.
Gel foam head ring. What about the head? Where should it be? How it should be? It should be how do you take care of the head and neck? The
Avoid
cervical
too much of
spine should
flexion.
be cervical spine should be in line with the thoracic spine. It should not be lower than or higher than the thoracic spine. Okay. So unless the patient has got a cervicothoracic scoliosis, all other patients for spine surgery, the cervical spine should be in line with the upper thoracic spines. Then only there will be no traction, no stretching injury, no venous engorgement, nothing will happen. And head can be kept in the neutral position or it can be turned to one side. Okay, so make sure that there is adequate support to support the head with the cervical spine in line with the thoracic spine. And if you are going to turn the head to one side, make sure that there is no compression on the dependent eye. It should be protected well by application of a soft gauze, and then eyes should be padded well and make sure there is no pressure and all. So what is the important visual complication that can happen in prone position?
Central retinal artery occlusion can occur.
Post-operative vision loss. It is called post-temporary or permanent post-operative vision loss. And the reason for that is so many things. Central retinal artery occlusion or the other edema, ischemia, all these things. Okay. So they are generally called as post-operative vision loss. Okay. To prevent that, this head and neck positioning is very, very important. Then which is the next area which you should take care of?
Peripheral nerves, sir, bony prominences.
More than that, before when you keep the pelvic support.
Genitalia.
More than the genitalia. More serious than genitalia. Of course, genitalia is also very important, but in a woman, genitalia may not be an issue. But the major vessels, because you are giving it at the groin level, the support is given at the anterior superior iliac spine and the junction of the abdomen and the thigh, isn't it? So the compression should not occur on the femoral vessels. That is very, very important. So you must make sure that there is no acute kinking or pressure on the inguinal region. That is the next thing. Then you take care for all the pressure points and wherever nerves are superficial, like ulnar, the tibial, all these things should be taken care of so that there is no post-operative neurological damage. Okay. This is called the head to toe survey. Whenever you position the patient prone, you should make what is called a head to toe survey of all the pressure points and all the vulnerable areas where injury can happen because of the positioning. Okay, right. So you have done all the positioning properly. You have placed all the monitors. You have started the case. So what are all the methods of maintaining anesthesia intraoperatively, and what are all the intraoperative complications you have to take care of, or problems that you can anticipate and avoid or prevent or treat?
Sir, regarding position
Mm.
related problems, as already discussed,
Mm.
and bleeding
Mm-hmm.
is
So,
major surgery.
yeah. So what are all the methods by which you can control or take care of the bleeding?
Sir, don't increase by positioning. Avoid any pressure on the intra-abdominal. Avoid intra-abdominal pressure, sir.
Okay.
Deliberate hypotension can be maintained.
Mm.
We can't reduce too much of BP or because it causes ischemia.
Mm. So spine surgeons don't prefer to have hypotension because they feel that the cord will be suffering from ischemia if you use too much of hypotensive techniques. So that also again a point you have to discuss with the surgeon whether he would like to have hypotensive anesthesia to reduce the bleeding, or should we maintain normal blood pressure to make sure that the spinal cord perfusion is maintained. This point also you have to discuss with the surgeon. Then, supposing he says, no, I want only normotension, I don't want hypotension. Then what are all the techniques by which you can reduce the bleeding?
The antifibrinolytics can be given, sir. Before
What is
giving
the dose? Normally we
Trans-
give antifibrinolytic in
tranexamic acid,
tranexamic
10 to
acid is
15
Mm,
loading dose 10 to 15 milligram per kg,
mm,
and maintenance infusion 1 mg per kg per hour.
very good. Then so that nowadays they say high dose tranexamic acid can be given as an infusion throughout the procedure also they can give after a loading dose. That is one method of reducing the bleeding. Any other method? Can you infiltrate the surgical area with some solution?
Local infiltration.
Local infiltration. Yeah.
Xylocaine with an adrenaline.
I used to use the Tumison local anesthesia for these surgeries with an excellent result. So with the cooperation of the surgeon himself can infiltrate the entire area where he is going to operate and retract the muscles, all these things. He can infiltrate Tumison local anesthesia at the rate of 10 ml per kg body weight. And that gives an excellent dry field with no bleeding at all. And it also adds to the intraoperative pain relief because you have a local anesthetic there, with making the requirement of other analgesic agents, reduced dosage can be used. Have you ever heard of that?
Yes, sir.
Yeah. So you know anything about Tumison to local anesthesia? How is it prepared? How is it used? What are the advantages, disadvantages? Any idea?
No, sir.
Where else do we use tumulus?
Pardon?
Where else do we use? Where else do we use tumulus? Because sir said tumulus now for this surgery. Don't have that.
Contracture release in Barnes patient.
Plastic surgery.
Where do they use it
Liposuction.
specifically?
Yeah.
Burns. Yeah, liposuction, burns, contraction,
Lipo-
neck.
Barnes contracture.
Yeah.
So now you say what is tumulus?
Right. So that is one of the method of reducing the bleeding. So you can either go for antifibrinolytic agent infusions, or you can use Tumison local anesthetic, or you have to accept the bleeding and replace whatever blood loss has occurred by either the stored blood or the available blood. That is the three things that you have the option, right? Supposing they want to do the neurostimulator intraoperative evoke potential monitoring, what are the precautions you have to take at the time?
Sir, cut down, if at all, any inhalational agents, if you are administration, cut down the inhalational agents.
Very
If
good.
your patient is on any muscle relaxant,
Mm.
stop, at least ask the surgeon to inform 30 minutes before the neuromuscular monitoring, so
Okay.
that we switch on to the total intravenous anesthesia, TIVA technique.
That we have already discussed, that if supposing the surgeon tells you in advance before starting the surgery that he plans to do the evoke potential monitoring, right from the beginning you go for TIVA only. Okay.
Sir.
But wake up test, supposing surgeon wants to do the wake up test, not using the evoke potential intraoperatively, but he has told you that he wants to use wake up test to find out the integrity. What are all the things? How do you prepare yourself for doing the wake up test?
Sir, I'll lower down my anesthesia level and ask the patient.
Anything to be done pre-operatively?
I should counsel the patient regarding the wake up test.
That is very, very, very important. You have to tell the patient that we will be lightening the plane of anesthesia and waking you up intraoperatively, but be reassured that you won't have any pain or anything. And you may listen to what I say. My command will be heard by you, and you have to oblige me, either by squeezing my hand or moving your foot. These are the two instructions I may be giving you. So if you hear that, you must oblige and do the instructions what I tell you. That is a pre-operative counseling is very, very important. Then only you plan for wake-up test intraoperatively in consultation with the surgeon. And surgeon should tell you well in advance, at least 30 minutes before he plans to want wake-up test to be done. So during that time, you reduce the inhalation agents. Then what are the precautions you have to take?
Sir, make sure that the patient won't buck severely and disconnect the ET tubes during the procedure and catheters.
Mm.
and the distraction of the surgical instruments. The patient
Mm.
should not be too light, sir. Should take care
First
of
of
this
all,
thing.
patient should be well anesthetized. I mean, I have analgesia. That is a very, very important thing. Supposing your analgesia has been inadequate intraoperatively, when the patient is made light and he becomes awake, they will react because of the pain. So make sure that there is no lack of analgesia in the period before you do the wake-up test. That is a very, very important criteria, practical application, because inadequate pain relief will make the patient react violently because they are coming out of the anesthesia. So make sure that there is no lack of anesthesia or analgesia. So what is the best method of providing adequate analgesia?
Remifentanil infusion.
Fentanyl infusion.
Remifentanil, talk something which you have already. If you are in the
Fentanyl
UK, you will say
Dexmedetomidine can
that
be
you,
used.
huh?
Dexmedetomidine can be used.
Dexmedetomidine, anything else much more superior than that?
Fentanyl
Dexmedetomidine, fentanyl infusion, anything else? Very, very powerful and very safe nowadays. Low dose ketamine is supposed to be very, very good. Okay, so you have to use a low dose ketamine right from the beginning of the surgery so that you don't have, the patient does not feel any pain along with your other analgesic agents. Okay, so if you do that, patient will be comfortable and then he will obey your commands, whatever you do. Okay, but at the make sure that everything is taken care of, his position, his tube, everything. He should not suddenly lift his head and disconnect or extubate himself in the prone position. That is the most important dangerous complication that can happen because of wake-up test. Any idea who described this test first?
Vasselle.
Vasuel is the Vasuel and Stagnara, okay, Italian surgeon and his anesthetist. Vasuel is his anesthetist and Stagnara, Pieri Stagnara is the surgeon who described that. So both of them carry the credit for that. And they are the people who described this wake-up test. Right. Okay.
So they say we can use a small dose of midazolam, sir, during that time, so that they will forget if they feel it is an unpleasant
That can
experience.
be given for making
Amnesia.
antegrade amnesia so that he doesn't feel that or have any psychological impact of that. That is the reason why we have to counsel and talk to them well before surgery so that they don't feel that as a inadequate anesthesia and problematic. Okay, so that is why you have to take care of the pain also if you plan to do wake-up test. Right. Okay. That. But why wake-up test is becoming not so popular nowadays? Any idea? Why
Not
they?
not that much reliable, sir.
Not that much reliable, but should be done as a last thing after all the fixation is done. Okay. So surgeon should decide to do wake-up test only at the almost at the completion of the surgery when he has finished all the distraction, fixing the screws and introducing the rod and all that thing. If he does any procedure after that, nerves can still get damaged after doing a positive or a successful wake-up test also. So the wake-up test should be done as a last and final confirmation after completing all the steps of surgery. So in between doing a wake-up test when the surgery is halfway through is useless because still you can produce a damage. So that is the reason. And second thing, because of the discomfort to the patient, like waking up him intraoperatively and then again putting him back to sleep, all these things are little cumbersome. So because of all these things, after the advent of evoke potentials, this has become not so popular as it was done in the ester years. And what is the name of the surgery that is usually done for scoliosis? Name of the surgical procedure?
No idea.
It's called the Harrington rod fixation. Okay, Harrington rod. They straighten the whole vertebral column from the curved position. It is made into a straight position. So the patient will find it difficult to bend forward after the surgery. Okay, because it is a steel rod which is fixed on both sides of the spinous process to straighten the entire vertebral column. So patient will have some difficulty in forward bending after the surgery is done. So that is this was introduced by one Dr. Harrington, and that is the Paul Randall Harrington, I think his name is, and otherwise it is called intraspinous fixation also. It's called intraspinous fixation with pedicle screws. That is the classical name for the operative procedure. Okay, right. Then any other modes of analgesia intraoperatively in the current scenario?
Blocks, sir.
What are all the blocks you can think of?
Erector spinal block and paravertebral block.
Very good. These
The
are
tissues
the
are
two blocks.
interactive. The tissues are intact and able to visible. We can plan for erector spine and paravertebral blocks.
So they can be given before the incision is made, because surgeon will be retracting the erector spinae muscle to reach the vertebral column. So it can be given prior to the surgical incision, and it can be used post-operative also. Any other method which the surgeon can help you?
Epidural catheter placements.
Very good. You can place an epidural catheter at the closure time, and through which you can use a continuous infusion of your local anesthetic agent. Have you ever done that?
Yes, sir.
Yes. So how do you do the infusion? What is the equipment that you use for the continuous infusion?
PCA.
PCA
Continuous.
is
No, suppose we'll give analgesic dose, sir, 0.125% BBOK.
intermittent. Not a. What is the equipment you require for a continuous low dose infusion of local anesthetic with an opioid?
Baxter pumps.
Elastomeric pumps. Baxter is a company. It's called elastomeric pump. It can be used, or you can use your syringe infusion pumps also. Okay, this is much cheaper and much mobile. Patient can be ambulated with a elastomeric pump, but you cannot mobilize the patient with a infusion syringe pump. So that is the difference between the two. Right. So these are all the methods of intraoperative analgesia. What about postoperative care?
Postoperative main problem, pain, sir, pain management.
Pain management.
And postoperative ventilation, sir. The patient is able to wean and he comes out. Then you plan for on-table extubation. We are planning preoperatively or intraoperatively. You are thinking any problem with ventilation, we'll advise postoperative ventilation.
Elective ventilation. Very good.
Take care of hypothermia also.
Very good. You have to prevent intraoperative hypothermia because of the large exposure as well as the ambient room temperature. Patient can become hypothermic. So that also to be taken care of. So how do you maintain normothermia in these patients?
For normothermia, we can use warm IV fluids,
very good,
warm infusion sets, and low flow anesthesia and HME filters can be used. Warm blankets can be used, sir. Warmers can be used. If surgeon permits, you can increase the temperature of the operation theater.
Very good, very good. Any DVT prophylaxis to be given?
DVT post-operatively can be given, sir. DVT.
Intraoperatively, what are the precautions you can do?
Sir, stockings can.
TED stockings to be DVT stockings to be applied. Okay, very good. So, Vasanthi, do you think any other points to be added to this?
So I think he said everything. Actually, I was thinking.
Venous air embolism, sir.
Only. So I was thinking of post-op ventilation.
Venous air embolism. Yes.
I said all that correctly.
The complication of venous air embolism.
Quite rare, but of course you have to keep in mind if there is a sudden drop in ETCO2.
And the monitoring, we should do all the monitoring that we are doing in the intraoperative period and well into the post-operative period. We should not miss any complication with
monitor the patient.
Yes, the post-op. That is as important as intraoperative monitoring. Just extubated them on the day mean you will not have any complication post-op. So that because after turning from the prone, when you put them back on the supine, after the procedure, there will be changes again. So that kind of monitoring is extremely important for these patients. Hemodynamic changes, massive hemodynamic changes will happen. So, so even invasive monitors. I think, did you mention about any intra-arterial line?
Arterial, no, madam. Arterial, intra-arterial monitoring
IBP?
also.
IBP.
Yes, ma'am.
Yeah, if supposing you expect a very large fluid shift or blood loss, intra-arterial line monitoring will be definitely useful, and especially if patient has got a compromised lung function also, to repeat the ABGs and electrolytes, it will be useful. So intra-arterial line should be thought of in cases of major multi-level fixation. Okay, right. Can I share the screen, Kamachi? Have you got?
Yes, please, sir. Yes, please. Screen is visible, sir.
Yeah, but this is it visible?
Yes, sir.
Yes, sir.
Okay. So these are all the various types of scoliosis that you can see. Supposing you see scoliosis in such a small child, what do you call that? This sort of babies. Is there a name for that? This is a little grown up. This is grown up, but this looks like a very small kid.
Juvenile, infantile.
Infantile scoliosis. Very good. Excellent. So this is infantile. So even at a very young age they can have. So these are all the patients who will have more of respiratory problem. That is the reason why I told you, you should ask when the parent noticed the curvature starting. So that is very, very important. So these are all the various types of scoliosis or curvatures that you can see. So the severity of the curvature can lead to skeletal maturity is very important, etiology, history examination, and clinical markers and decision making. When to operate or when to do conservative management is a very important point that you have to think of preoperatively. Coming to the definition of scoliosis, it's a lateral curvature of the spine greater than 10 degrees as measured by Cobb method on a standing X-ray of the thoracolumbar spine. These are all the conditions that we fulfill. You cannot do a sitting or a lying down X-ray. It should be a standing X-ray of the thoracolumbar spine, and it should be an AP view, not a PA view, as you do for routine chest X-ray. And this is how the changes happen. See, this is the vertebral bone with the body, this transverse spinous process, transverse process, and the lamina. So the whole thing rotates, and you see the rib cage, the convexity side and the concave side. And the classification based on it can be a thoracico-cervical, thoracic, thoracolumbar, or lumbar, or combined double primary. So it can be a combination of any of these areas. And the other classification is based on the etiology. Here it can be idiopathic or congenital, vertebral open, vertebral close, neuromuscular, neurofibromatosis, mesenchymal disorders, and traumatic. All these are all etiological causes. And the measurement of severity of the Cobb's method is by drawing a line from the top starting vertebral upper surface of the body from on the lower vertebra, the lower surface, both of them meet, and this angle is also called a Cobb angle. Okay, so or you can draw a perpendicular line from both the lines, and then the angle which they cut and form, that is also a Cobb angle. So if you don't have facility for drawing this line, you can take this line alone and do that, and measures a complex deformity only in 2 dimensions. And this is the person who described that, who is called John Robert Cobb, American orthopedic surgeon, who lived from 1903 to 1967. He lived only up to 64 years of age, but he described this in 1930 as a young intern in orthopedic department. And the deformity, when was it first noticed? How was it noted? Is it progressive? What treatment has been taken so far and how long? Details of old records and x-rays. any bracing or any corrective procedures attempted before the plan for surgery is very important. And coming whether the patient has any pain, which indicates the neurological involvement. Idiopathic scoliosis does not cause pain. That is why it becomes slowly progressive, because it doesn't cause a painful problem. Patients fail to notice it. And the neurologic symptoms, especially when it is an angular kyphosis, gait problems and loss of balance also will be happening. And the cardiopulmonary problems has been well described. So you can have restrictive type of lung disease. Because of that, secondary to that, you will have cardiology problem like pulmonary hypertension, right ventricular failure, and all those things. So this picture will show you how the rib is formed here. See, this is the curvature, it is going on, and you can see these ribs are all opening out nicely. Whereas here you can see these ribs are getting crowded. So the concavity side there is crowding. On the convexity side there is splaying, or the ribs getting widened out. The history, any birth history, whether there is any problem during pregnancy, whether the mother was an antenatal diabetic mother or any care needed, all these things are to be taken in case of younger children coming for surgery. And the development of the patient, milestones, learning disabilities, all these things all to be taken care of. And any family history of parents or siblings suffering from similar disease. It's because it can go in for in the families, it can run in the families. And past medical history of any hearing, visual problem, associated cleft lip and palate, tracheoesophageal fistula, all congenital anomalies, or genitourinary disorders and neurological disorders. And of course, past history of any tuberculosis is very, very important. And physical examination, you must do a spine examination, head to toe examination, and a neurological examination. And the equipment that you need for examining a patient, of course, we are not orthopedic surgeons or spine surgeons, but these are all the equipments that they normally use. And how do they use, you will see in the next few films. So first look at the patient for gait, posture, spinal alignment, the skin over the curvature, and sexual maturity. Feel for any tender spots or step-offs or paraspinal muscles. Measure the height and weight and ask the patient to move, range of movement and flexibility. So look, feel, measure and move. These are all the 4 steps that should be done in examining a patient with scoliosis. And when the posture is noticed, normally head should be centered over the pelvis. So the pelvis and the head should be in a vertical line, should be normal. And hip and knees extended, pelvis is horizontal, shoulders are in equal level, and neck is neutral. This is the normal posture. Whereas when you have the deformity, all these things will get altered. And this spinal alignment location, you must find the apex of the curvature, side, whether it is right side curvature or left side curvature. And sometimes when combined deformities are there, which one is a major curve, whether it is a thoracic or lumbar. And then symmetry of the shoulder, rib prominence and lumbar prominence, waist asymmetry, pelvic obliquity, all these things, lower limb deformity, hip examination, and flexibility, all these things should be tested for. Now, this is a classical case like what we have described. A 15-year-old girl probably with a nice huge curvature, 60 more, this will be more than 60 degrees. And you can see there is crowding of this thorax here. On this side it is more open. And this is the side view of the patient. And you can notice there is she is lifting her left leg to stabilize herself. So both the postures, the left leg is lifted up because of this deformity. And when you start examining from the back, first to see the shoulder level. Here the left shoulder is tilted and right shoulder is a little up. And the rib prominence is there here. Asymmetry of the flank crease is at a different level. And then if you see the head position, this is how you measure that head neutrality. Using this is something what the masons use during construction, the same level to find out the length and the alignment. And the trunk decompensation, how much is the trunk bent? That is another method. That these are all mostly for the surgeons, but anyway, you should also know. So this is the flexibility, the aid, how much the patient can bend, and then whether you are able to insinuate your finger, and the gap is very important. And then you must always do the Adams forward bending test to find out what is the patient's this thing. So here you can see the hump due to this very prominent scapula, projecting scapula. The instrument that they use is called the goniometer, Goniometer. Goniometer is used to find out the difference between these two. And the rib prominence, you can see either it can be a sharp prominence or a smooth prominence. And again, the lumbar prominence, you can see there is a projection here compared to the opposite side. So both the rib and the scapula, all these prominences will tell you about the severity of deformity. And when you see from the frontal view, this is a much lesser problem, whereas this is much greater problem. See, the head is here, the body is tilted here. So there is an asymmetry of the chest. So all these things you have to notice. And the side view, again, you have to make sure and identify the different types. Now, this Cobb's angle, less than 10, you won't have any problem. Whereas more than 25, there will be increase in the pulmonary artery pressure. 40 and more, you have to think of surgical correction. And 70 or more, there should be decrease in lung volume. And more than 100-degree patient will be usually having dyspnea on exertion. More than 120, there will be alveolar hypoventilation, and chronic respiratory failure also will be present. Now the treatment part of it, it can be non-surgical, where you can put braces, traction and other applicants, and then surgery, it can be either a posterior approach or a combined posterior and anterior approach. So that is another important point which we have forgotten to discuss is if it is a combined anterior and posterior approach, sometimes you may have to use a double lumen tube to isolate the lung on that side. So it's one of the relative indications for intubating the patient with a double lumen tube, where it is you do a anterior and a combined posterior approach. Those days they used to call it as Hong Kong surgery. I don't know why they called it. Probably it originated in Hong Kong. And the pre-anesthetic assessment, we must assess the airway thoroughly. Difficulties may be anticipated with the especially upper thoracic or cervical spine if it is deformed. And traction may interfere with securing the airway. And Duchenne muscular hypertrophy patients may have a tongue hypertrophy. I think this is not well seen in this picture, but if you look at the close picture of that, it will be these children have an enlarged tongue, which may make intubation difficult. And in the respiratory system, it causes a reduction in the vital capacity. So patient should be nicely given a preoperative incentive spirometry so that they can cough well in the post-operative period, and FRC will be also reduced. Restrictive pulmonary disease pattern will be seen. So it will be more with the angle and number of vertebrae involved and the location of the curve. So that is the importance of examining the back and the thoracic curvature, everything for our assessment of respiratory system. So conservative management of mild and infantile scoliosis can be done by what is called Risser and Mehta casting. So sometimes you may be asked to give anesthesia for that for small children also. That is the reason why I thought I will put up this picture. They have already given anesthesia for this. It is put on a frame, and then plaster of Paris cast is applied to the entire body. This cannot be done with a conscious child. So sometimes you may be asked to give anesthesia for this also. And whenever they put the cast like this, they must give adequate gap in the abdomen so that the child can easily breathe. So this is called the pear-shaped opening or a hourglass opening for the tummy. So This is how the adult can wear these braces and cast and then wear their dress and go out also. And the pre-anesthetic assessment, of course, we have seen that respiratory system, there is a reduced VC is the first magnification. So when you measure the vital capacity, it is reduced. And prolonged periods of hypoxemia gradually will result in pulmonary hypertension and hypercapnia and eventually respiratory failure. This all will happen in a very severe case of scoliosis arising from a very younger age. And the surgery is done in these patients to prevent the complications of the respiratory tract also, this sort of changes. And they limit the respiratory muscles become tired, and it limits the activity also. And flow volume loops can show evidence of obstruction also in some cases, and neuromuscular dysfunction also can happen. And preoperatively, respiratory function should be assessed by history, focusing on functional impairment and effort tolerance. This is very, very important. The patient has a normal effort tolerance, that means the lungs are functioning normal. On the contrary, if the child is not able to do their routine work and becomes breathless, that's a very ominous sign. And preoperative incentive spirometry is very important to make them comfortable in the post-operative period. And cardiovascular system, mainly they are all more or less common, but it is secondary to the chronic respiratory insufficiency. It is not a primary problem. So ECG echo will show all these things that happen in the cardiovascular system. Neurological assessment is also very important. If the patient has already some sort of weakness or loss of sensation in the limbs, then that has to be documented. Otherwise, what can happen? They can blame the surgeon and anesthetist for the loss of neural integrity. So that has to be properly documented. And the anesthetic technique, avoid use of narcotics and heavy premedication if there is a lung function impairment. You can use bronchodilators if there is any obstructive feature, anti-sialagogue, H2 receptor and proton pump inhibitors. All these things are normally given as a routine. And induction, we usually go for intravenous route induction. And succinylcholine, we have to better avoid as much as possible because of hyperkalemia or the possibility of malignant hyperthermia or King-Denborough central core disease and adenylate kinase deficiency. So use of non-depolarizing muscle relaxant may be better for intubation. And after intubation, if there is an anterior approach, as I said, you have to go for a double lumen tube for lung isolation. If it is a simple, straightforward posterior approach, you can use a single lumen tube and preferably a flexometallic tube so that there is no kinking. Then maintenance of anesthesia, you have to have a stable anesthetic depth to enable proper interpretation of evoked potentials. So you can avoid nitrous oxide also if the surgeon is planning for this monitoring, and go for oxygen air mixture. And non-depolarizing blocking agents are used if these things are not planned. You can go for a conventional control ventilation. Otherwise, you have to go for intravenous anesthesia, total intravenous anesthesia. The regular monitoring, including temperature output and urinary measurement, and blood gas can be measured intermittently in large major surgeries. Intravenous fluid should be warmed, and warming mattresses should be used to maintain normothermia. So this is the picture how the frames support the patient in the chest as well as in the pelvis region. So depending upon the level of the spine to be operated, the nature of the proposed surgery, you have to take care of the peripheral nerves, eyes, genitals, bony points, etc. Intraoperative imaging may be often required. So the C-arm usage will be there. So that is, you have to protect yourself, and the surgeons also will be wearing the lead sheet and other things to prevent from the radiation hazards. So the positioning should be done in such a way that there is no interference with the imaging, because they are going to put screws and then fix, and they have to know what is the depth they are going. So the patient should be ideally positioned in the central area without any metal or rod projecting in that area. And it requires an uncompressed abdomen. Very, very, very important point. This, even if you have not have this much of gap, at least your hand should be able to go between the abdomen and the table. So this is what I, and prone position for spine surgery. So the first stage, you always start with the patient induced in the stretcher. And you have see all the pillows and the supports are all well positioned. So anesthetist is standing here and people are one person ready to lift, another person ready to receive. So, and another person to stabilize the trolley. All these things are there. So I can imagine this is what I asked in the very initial starting of anesthesia. And you have to disconnect all the IV line and monitors. Already the dead stockings, everything is in position, and they are now going to turn the patient. And this is how the patient is positioned with the urinary bag placed here. And so this is the classical normal position many of the surgeons use. And you can see the C-arm is already there, which can be easily moved underneath the table. And then you can locate whatever level you want. And sometimes they ask for this sort of position. This is called the jackknife position. So surgeons, when they want to open up the spine more, instead of the patient having a stretched limb on the table, they bend it and bend the pelvis so that the lower spines will open out nicely. So this is called the jackknife position. And again, you can see all the TED stockings are all placed here, and the ECG leads are all placed on the back, not on the front. So this is the reason why I normally don't place the ECG unless the patient is having any cardiac issues earlier. So this can be placed after the positioning of the patient. And this is the way you have to manage a patient with a huge belly like this. So you can see there's a big gap here to allow the abdomen to hang freely, and there is a lot of gap between the table and the thing. So the frame is lifted up so that the belly doesn't touch the table. So this is how you manage a person with a huge midriff. And when you want to do total intravenous anesthesia, you always have the infusion pumps ready. So you can use dexmedetomidine here and a propofol infusion and maintain the intravenous anesthesia. So dexmed, propofol, TCI, and ideal when neuromonitoring is contemplated and neuromuscular blocking to be avoided. And if you are using TIVA, it's better, preferable you have a BIS monitor also, so that you don't keep the patient awake. So if you have a BIS monitor, you are confident that the TIVA is maintained at adequate depth, so that patient is under full anesthesia. So it is needed when UA is used. Now the common method of doing a block before as a part of multimodal analgesia during intraoperative procedure, this is what is called what is the block they are giving? They are giving the serratus anterior block and our erector spinae muscle block. So you can use the ultrasound. This is the way the probe is held, and this is the way the in-depth needle is introduced. And it is very easy to just go at the spinous process, transverse process, and then this is, you can see, this is the sono diagram, caudal and cranial. From the skin, trapezius muscle, rhomboid muscle, erector spinae muscle, then there is a transverse process. So just you go and hit the transverse process, withdraw, and just inject about 20 ml. So if you know the S1 anatomy, it's very, very easy to do that. And then these are all the anatomical structures. See, this is the vertebral body, this is the vertebral canal, and this is the trapezius muscles, rhomboid major, erector spinae muscle, transverse process. The probe is here and the needle is gone. You go and hit the transverse process, withdraw gently, and then inject the drug under the erector spinae muscle. So these are all the various supports. The first one is the simple bolster, which majority of the hospitals will be using. So you can see the two rolls here, one on the top and one on the time. The second one is called the Montreal mattress. So this is the Montreal mattress with a gap for the abdomen to be left free. The third one is the Jackson operating table. The fourth one is the Wilson frame. So this is the Wilson frame. And the fifth one is the Andrews operating table. So there are all some of the different types of supporting systems. When you put the patient in prone, care to be executed to protect the eyes, keep the abdomen free, prevent compression of major vessels at groin, avoid excessive abduction of upper limbs, proper padding for all pressure points, and cover all exposed part to prevent hypothermia. So these are all the things that you have to take care of in the patient. And of course, make sure that the urinary catheter is not compressed or kinked and it is properly draining. And this is the how you will see the surgery. So this is the A is the first exposure. So long thoracic scoliosis, it requires this much of exposure up to all the vertebra. And then one side they have put all the screws and the rod. And this is the other side that they have completed. So it is a bilateral fixation which you have to do. And ultimate final picture looks like that. And he is the person, Paul Randall Harrington, who devised this. So this rod is called as Harrington rod. This is a rod which can be bent and then which can be introduced. These are all called the pedicle screws. So in the gap between that, you introduce this rod to finalize that. And this is how the pedicle screws look like. So they put it in the pedicle of the vertebra, and then the head holds, this gap holds the rod. Okay, and then again, this is the picture of the post-operative picture. So you can imagine what was the curvature here like this had been straightened. So patient will definitely have some difficulty bending because of these rods. So they will have, but their other problems will be rectified. And sometimes examiners may ask you about the arterial and venous drainage of the spinal cord in this sort of surgeries. So all of you might be knowing that there are two anterior spinal arteries and one posterior spinal artery coming from the vertebral artery, posterior inferior. So these posterior spinal arteries and anterior spinal artery, they are all supplemented by one artery of Adamquish from the intercostal vessels. Okay, and another branch here coming from that. So this anatomy I thought will be useful. And then spinal cord monitoring. That's what we do during the surgery. And wake-up test was first done by Stagnara in 1973. So all that we talked about, and SSCP and MEP, this is also asked as a short note question in your theory paper also. So how is it done? What is the importance of that? And they are disrupted by inhalation agents greater than 0.5 Mach and nitrous oxide. So if you are planning to do evoked potential monitoring, better to avoid volatile anesthetic agents. And neuromuscular blockade also disrupts motor evoked signals, most commonly done with the total intravenous anesthesia technique. Depth of anesthesia to be monitored using a bispectral index monitoring, which I already showed. Hypoxia, hypercarbia, hypothermia, and hypotension, all these four things can interfere with this monitoring. So you have to be very watchful. And the drawback of wake-up test requires patient's cooperation, risk of patient moving or falling off from the table and extubation happening, and it requires the skill on the part of the anesthetist to control and lighten the plane of anesthesia. Measures motor function at the time of testing and not continuously. So as I told earlier, it should be done as the last step before closure. Otherwise, if there any further procedure is done, then it can again get affected. So Tagnara is now confined only to electrophysiological monitoring if it is not available, or if it is not properly functioning, or if they show an equivocal result, then you do the Stagnara wake-up test. And this is how all the electrodes are placed for motor evoked potential, because you have to stimulate the motor cortex to get a response in the concerned muscle. So all the electrodes are placed in the scalp and then stimulated. Whereas if you want to do a somatosensory evoked potential, you have to stimulate a peripheral nerve and then get the sensation going to the cerebral cortex, which will be recorded there. So you usually do the posterior tibial nerve stimulation. So the electrodes are placed on the limb that is exposed, and this is how the electrodes are placed. And this is how the monitoring will be done intraoperatively by the electrophysiologists. So they will show when the simulation occurs, you find there is a curve going up. So left hand, right hand, all these things can be stimulated, and this is how the monitor will look like. This is the display. And the second important thing is the blood conservation. So blood loss usually 10 to 30 ml per kg may be there. So you have to keep the allogenic transfusion to the minimum. And this is accomplished by reducing the blood loss or by autologous transfusion. So method of reducing the blood loss intraoperatively is to make sure that there is no intra-abdominal pressure. That is why I repeatedly said, make sure that the positioning is important to allow a free movement of the abdomen. Hypotensive anesthesia is it's a controversy. If the surgeon accepts, you can do that. Majority of the surgeons won't accept for that for fear of ischemia to the spinal cord. And mean arterial pressure is typically maintained at 60 to 65. And antifibrinolytic agents like tranexamic acid infusion continuously throughout the procedure is the current method of reducing the blood loss. Now, autologous blood transfusion, as I said, there are three techniques: preoperative donation, acute normovolemic hemodilution, and intraoperative cell salvage. And this is how the cell salvage is done. Blood is collected from the operated field, and then saline heparin or anticoagulant mixture is added to that. Then isotonic saline will be washed and the whole thing collected and then retransfused to the patient. Post-operative care, patients should be cared in ICU and then 24-hour monitoring, and neurological injuries, ileus, pneumothorax, dural tears, urinary complication, and sometimes rarely syndrome of inappropriate ADH secretion also can happen. Post-operative analgesia, multimodal approach again, intravenous opioids by infusion or by patient controlled analgesia, non-steroidal anti-inflammatory drugs. Intrathecal opioids can be injected before closure. Epidural can be done, but it will make the neurological assessment difficult. That is one drawback of that. And intrapleural infusions for local anesthetic or opioids if it is a higher up thoracic correction. And low dose intravenous ketamine, even in the post-operative period, especially for those who are opioid addicts. The best method of analgesia is giving low dose intravenous ketamine. Post-operative visual loss is one of the important complications. It can be partial or complete vision loss occurring after general anesthesia for non-ocular surgery. It's an uncommon complication, but rarely it can be there, associated more with cardiac surgery and procedures on spine done on prone position. These are the two surgeries where you can get this. And the causes are, it can be an ischemic optic neuropathy, or it can be a central artery occlusion, or it can be a cortical blindness, or it can be a posterior reversible encephalopathy syndrome. This press syndrome is more common in which particular patient? Have you heard of this in ladies? Preeclampsia patients may have posterior reversible encephalopathic syndrome. And pathophysiology is ischemia to visual pathways, particularly the optic nerve and retina. Major source of blood supply to retina and optic nerve is the ophthalmic artery, branch of internal carotid artery. So that is why neck positioning is very, very important. And branches, central retinal artery and long and short posterior arteries which supply the retina. And increased venous pressure in the globe or interstitial edema due to prone positioning. or increased intraocular pressure, compression of vessels supplying the optic nerve, and hypoxia of optic nerve. This is a series of events which will result in this particular problem. And the risk factors are lower post-operative hematocrit, presence of clinically significant vascular disease, and if it is a cardiac surgery, long duration of cardiopulmonary bypass or red cell transfusions and use of other blood components, all this have been associated with that. And retinal ischemia can happen because of all these reasons. In spine surgery, it is due to improper patient positioning and external compression of the eye. This is a very, very important point. That is why you must give very, very good care to the head and neck. And this is one of the adult uncorrected scoliosis patient. I thought I saw an interesting article on a patient needing a nephrostomy. Already he has got a nephrostomy on one side because of hydronephrosis, and now he needs a nephrostomy on the other side. This is the lateral view of this patient. This is the X-ray of the patient. How they anesthetize him, he cannot lie completely on his back. So patient was positioned semi-prone, and then anesthesia was induced, and they had some difficulty in intubation. They used a video laryngoscope to intubate, and then completed the surgery in this position itself. Okay. So, any questions?
Thank you very much, sir. Now the session is open for questions. Students, any questions and doubts?
I think some question I saw in the chat box, somebody patient cannot talk. It is not the question of for wake-up test, the patient need not talk to you. He has to only listen to you, and that's why you have to pre-operatively tell them what are the commands you are going to give. You have to say that you squeeze my right hand with your left hand, or you move your toes, move your foot, right foot, left foot, like that. You have to tell all that to the patient pre-operatively, and then give the same commands to the patient after lightening the plane of anesthesia. And if the patient is able to do that, it shows that the nervous system is in continuity and functioning well. Whoever asked that question, that's the answer for that. Any other questions in the chat box? Okay, if there is nothing, we will go ahead with the next topic, or Sanjeev?
Sir, good evening, sir.
Hmm.
I have one complication that I thought I will discuss in this session, so
Okay.
that I can have the input and PGs can also
Can you
learn.
please introduce yourself, please?
Sir, I'm Dr. Shantini.
Hmm.
I was previously here in Railway Hospital, sir.
Okay, okay.
And now working in ESI Kerala, sir.
Okay, okay. Tell me.
So this was a 46-year-old female
Okay,
coming for transabdominal hysterectomy, sir.
okay.
And this was a long-standing fibroid,
Hmm.
and patient was also anemic previously. From previous records, she was continuously anemic, and I
Okay,
think there were 2 previous transfusions given in the same year.
okay.
Otherwise, she had 2 previous LSCs also.
Hmm.
And the fibroid was also quite large, sir. Somehow
Okay.
in Kerala, we have been seeing this series of fibroids which are multiple and which are quite.
Okay, okay.
This fibroid also was one of this variety. And
Okay.
so we had just arranged blood,
Okay.
and we had also consented for a regional previous day. And
Okay.
I did not find, we had an echo also previously, sir, and it was normal.
Okay.
There were no other, nothing of concern.
Okay.
The operative surgery lasted, we gave a epidural and spinal, sir.
Hmm.
Standard epidural L1, L2, and spinal in L3, L4. We had given 3.2 ml of sensocaine, 0.5 sensocaine with buprenorphine, sir.
Okay.
And since this was not a very great spinal, I think, and so we had to top it with the epidural at about 45 minutes itself.
Okay.
And this was also dense. So we had given totally 3 doses of, since it was not a very well acting spinal, we had to give only lignocaine 2%.
Hmm.
So we had given that 6 cc of lignocaine, no, 6 cc in the first shot, and then 5 cc, 5 cc. So there were three doses of epidural given, sir,
Okay.
for 3 hours, totally 3 hours. So the operation lasted for around 3 hours, and otherwise it was we gave one blood loss was around 1,400, sir.
Hmm.
We had but her preoperative hemoglobin was 12.5.
Okay.
And since we had also calculated, we gave 1 pint
Okay.
transfusion,
Hmm.
and then there were no hypotension, nothing
Okay.
at all, sir.
Okay.
Intraoperatively, we used one heat steroid and one blood transfusion and
Okay.
3 crystalloids, sir.
Okay. Okay.
Next day, actually, the patient in the morning, she had complained to the sisters that
Hmm.
she's having one side numbness.
Okay.
That time we examined, her motor power was weaker on the left side.
Okay.
On the right side, sir. On the right side, her motor power was weak.
Okay.
Left, she was able to do everything normally. Right side, she was able to do, but it was weak.
Okay.
And joint position was normal. Sensation was also, she was able to feel. But
Okay.
she was complaining of some dysphagia, kind like in the feet
Okay.
alone.
Okay.
So we gave her reassurance, and we decided to have wait and watch approach.
Hmm.
Evening, we again examined her after 8 hours. Sensation had improved, and she was actually able to do the. Since we were more concerned with knee joint and this, we were actually testing all that, and it was all quite normal, sir.
Hmm.
We had, and then
Now-
next day morning, we tested again, and she had quite difficulty extending the legs.
Hmm.
Hip alone was with difficulty she has, but otherwise sensation was normal,
Hmm.
and nothing else we could do. So we did. This was a district general hospital. There was no facility of MRI. No, but previously itself we had asked to take out the epidural on the first day itself, since there was some question of neurological impairment. We had taken out the epidurals.
Hmm. Okay. So you wanted to discuss this because we are discussing a spine surgery case, or
No,
it is
you
this is
also said documentation of neurological this. How to go about this documenting neurology?
See, if the
And
patient has a weakness or any problem, sensation, altered sensation before the surgery itself, you have to examine that and then you have to document. That's what I mean. So
yes,
that you can prevent any litigation issues later on. So,
yes.
whereas a patient who has no neurological deficit after a procedure like this, when you do a combined spinal epidural, there are so many things that can go wrong to produce this problem. Either it can be a nerve injury or it can be a hematoma. All that, unless we investigate them completely, we do not cannot make a diagnosis. And
Yes,
any intraoperative prolonged hypotension also is another possibility which can cause, and that is the reason why I told you the hypotensive technique is not preferred by some surgeons. They don't want that to happen because prolonged hypotension can cause spinal ischemia and post-operative neurological deficits. So we will have to investigate and then only be able to come to a conclusion why there is a unilateral motor weakness in this patient. So either it is a spinal cord level or at the cortical level, we'll have to examine and get a neuro opinion and then investigate them properly to get the idea about it.
Yes. Sir.
Right.
Mm.
Right.
Mm.
Uh,
Is there anything that we could do if we are not able to get a neurologist consultation, if it is a district general hospital, and surgeons are also
No, at
not
least we
able
must have some basic investigation available, no, to make a clinically you cannot you can just say there is a 3/5 or 4/5 motor weakness. That's all we can elicit by neurological examination. But if you
Okay.
want to find out the etiology, we definitely need to have an MRI scan or other neuromuscular evoked potential studies, all these things to find out whether it is a supposing the sciatic nerve problem is there or a femoral
Mm,
nerve problem is there, that can be
mm.
found out only by the neurophysiological studies. So without that investigations, it is not possible to clinically make a diagnosis.
Okay.
Uh,
Luckily, this patient improved, sir. No long-lasting sequelae.
Okay, thank God. Then you are lucky.
Yes.
Okay, right.
So, but I thought, what will be the right way to document? Is there
Uh,
anything for these medico-legal issues? That's what I thought I'll get to.
No, documentation is post-op. You have to document everything sequentially, correctly. When it happened, how long it lasted, when she started improving, what are all
Mm.
the clinical findings, everything that you have to document correctly so that when the patient recovers, now nobody will trouble you. Only when if there is a permanent damage, they are going to bother you and give you a headache.
Mm, mm.
Okay. Right.
Okay, sir. Thank you very much.
Thank
Thank
you.
you, sir. Thank you. Dr. Sanjeev is there.
Is there or
Yeah, Dr.
Yes, sir.
Sanjeev. Yeah.
Yes, sir.
shall I go ahead with the presentation and complete it so that it need not be a repetition, or does he want to present? Sanjeev Raju. Sanjeev Raju, are you ready?
Yes, sir.
Yeah, you go ahead and present it quickly.
Okay, sir.
Mm.
Good evening, everyone. Today, my question of presentation is about neonatal resuscitation. First, we start with the algorithm. Initially, we do the antenatal counseling, then team briefing, and then equipment check. Then, at the time of the delivery, we see whether the gestation is of term gestation and the baby neonate has good tone and has good breathing or crying efforts.
Very good.
If all these are present, then we can give the neonate to the mother to keep the neonate warm and maintain the normal temperature, and then position the airway and clear the secretions if needed.
Very good.
And if above all these are absent, then we should clean the patient and warm the patient and then maintain the normal temperature. Then again clear the secretions if needed. Then if neonate has apnea or if she has gasping, or if the heart rate is less than 100 per minute, if above the if apnea or gasping is present, then we should start with positive pressure ventilation, SpO2 monitoring, and then consider ECG monitoring. And if apnea or gasping is absent, if she has only labored breathing or persistent cyanosis, we should position the airway and then clear the airway, then monitor SpO2, and then supplementary oxygen is given as needed, and then consider CPAP measurement. If still further neonate has heart rate less than 100 per minute, we observe whether the chest movement is there, and then ventilator corrective steps should be done, and then we should intubate the patient with ET tube or LMA if needed. And if heart rate is not less than 100 per minute, if it is above 100 per minute, then we can use post resuscitation care and then do the tip briefing.
Very
If
good.
still heart rate is less than 60 per minute, even after ventilator corrective steps are done, then chest compression should be started, with the two finger technique, two finger and encircling technique, and then positive pressure ventilation should be continued. Then 100% O2 should be given. SpO2 monitoring and ECG monitoring should be done. And then IV lens intravenous access should be done using umbilical venous catheter. Even if still the heart rate is less than 160 per minute, consider giving IV epinephrine at the dose of 0.01 mg per kg, 0.01 to 0.03 mg per kg. This IV epinephrine can be repeated at 3 to 5 minute interval. If heart rate is less than 60 per minute, even after epinephrine administration, consider in a therapeutic therapeutic hypothermia, and then give the post resuscitative care. And then under the following headlines, initial umbilical cord management, it is recommended that the term infants who are receiving early cord clamping, compared with the term infants receiving early cord clamping, those with delayed cord clamping had increased hemoglobin concentration within the first 24 hours and increased ferritin concentration in first 3 to 6 months. It is reasonable to delay cord clamping for more than 30 seconds in preterm babies because the delayed cord clamping reduces need for blood transfusions and also it maintains the blood pressure support. Temperature management at birth and in the newborn infants. Immediately after delivery, babies should be kept skin to skin with the mother. In case of preterm babies, preterm and low birth weight babies who require resuscitation, warm adjuncts should be warm adjuncts like radiant heat warmer or blankets, exothermic mattress, and warm and humidified inspired gases can be given to maintain the temperature. When the babies are in out of hospital setting or in limited resource setup, it is reasonable to use clean food grade plastic bag as an alternative to skin contact. And coming to clearing the airway and then tactile stimulation, in babies who are breathing well or crying, routine oral nasal suctioning and tactile stimulation is not recommended. Avoiding the suctioning reduces the risk of induced bradycardia. In babies with ineffective respiratory efforts, tactile stimulation is beneficial and suctioning may be considered if positive pressure ventilation is required and the airway appears to be obstructed. Then in newborn infants born through meconium stained liquor, in case of non-vigorous newborn, that is baby with apnea or if it has ineffective breathing efforts, delivered through meconium stained amniotic liquor, tracheal suctioning is beneficial. Assessment of heart rate during neonatal resuscitation. During resuscitation of term and preterm newborns, the use of ECG for rapid and accurate measurement of newborns for heart rate is reasonable. Use of ECG does not replace the need for pulse oximetry to evaluate the oxygen saturation or need for supplemental oxygen. Then coming to ventilatory support after birth, during the initial breaths in the newborn infants who are either gasping or apneic, even within 60 seconds after the birth, or who are bradycardic, that is heart rate less than 100, despite appropriate initial actions, positive pressure ventilation should be provided without any delay. The positive pressure ventilation should be given at the rate of 40 to 60 inflations per minute. In newborn infants who require positive pressure ventilation, it is reasonable to use the peak inflation pressures of up to 30 centimeters per 30 centimeters of water in case of term, and 20 to 25 centimeters of water in case of preterm. In case of preterm infants, the positive pressure ventilation should be given with an inspiratory time of 1 second or less. Then considering the CPAP, and for CPAP is considered in case of spontaneously breathing preterm infants. who require respiratory support after delivery. Then coming to oxygen administration, in term and late preterm newborns, initial use of 20%, 21% oxygen is reasonable.
Very
In
good.
case of preterm babies, oxygen support can be given at from 21 to 30%. In term and late preterm newborns who are receiving oxygen support, giving 100% oxygen is harmful.
Very good.
Then coming to chest compressions, if heart rate after birth remains less than 60 per minute despite adequate ventilatory efforts for at least 30 seconds, chest compression should be immediately started. Uh, during the chest compressions, it is advisable to use higher concentration of oxygen. Then coming to compression to ventilation ratio, it is reasonable to deliver the compressions at the rate of 3 compressions with 1 ventilation. It is better to use 2-thumb encircling technique over the 2-finger technique, as it is associated with improved blood pressure, and then less provider fatigue. Then coming to intravenous access, for babies requiring vascular access at the time of delivery, umbilical venous catheterization is the recommended route. If the intravenous route is not feasible, intraosseous route is recommended.
Very good.
Then coming to medications used in neonatal resuscitation, if the heart rate has not increased up to more than 60 per minute, even after chest compressions, positive pressure ventilation, it is reasonable to administer IV epinephrine at the dose of 0.01 to 0.03 milligram per kilogram. If IV access is not available, epinephrine can be given via endotracheal route at the rate with the dose of 0.05 milligrams to 0.1 milligram per kg. Then further doses of epinephrine can be administered every 3 to 5 minutes, preferably IV if the heart rate remains less than 60 per minute.
Very good.
Coming to usage of volume expanders, when the blood loss is suspected in a newborn infant who responds poorly to resuscitative efforts such as ventilation, chest compressions, or epinephrine, it is reasonable to administer volume expanders without any delay. The 0.9% normal saline is the fluid of choice. And then uncross-matched blood of O negative type is preferred when the blood loss is substantial. And the initial volume of 10 ml per kg over 5 to 10 minutes is recommended, and it may be repeated if there is an inadequate response. Then coming to the post-resuscitative care, in newborn infants who receive prolonged positive pressure ventilation or advanced resuscitation, they should be transferred to a neonatal intensive care unit. And then these newborns are more prone for hypoglycemia, so glucose level should be monitored as soon as possible. And then for the newborn infants who are unintentionally hypothermic after resuscitation, it may be reasonable to rewarm them either rapidly, with at the rate of more than 0.5 degrees Celsius per hour, or slowly, that is less than 0.5 degrees Celsius per hour. That's also post-resuscitative.
Okay. Now you have done a wonderful job, excellent preparation. But I would like to add a few more points to this. You have more or less covered all the points. But
Yes,
first
sir.
and foremost, if this is a theory question appearing in your theory paper, you must first define what is neonatal resuscitation before you straight away go to the algorithm or flow chart. I think you
Okay, sir.
first define what is a neonatal resuscitation.
Okay, sir.
Can you define what is a neonatal resuscitation? What is the definition?
Definition.
It can be defined as the acts or the measures to be taken for
Okay, sir.
infants who are not able to transfer themselves from the intrauterine circulatory method to the extrauterine life. Okay, intrauterine, their lungs are not working. They are
Yes, sir.
dependent on the placenta for all the functions of their life to be alive. Whereas
Yes.
once they are born, They get a transition from the placental circulation to the lungs getting opened up and the regular circulation starts. So children
sir.
who are babies who are not able to go into a smooth transition like this, they are the ones who suffer from this part of problem. So they only require the assistance or resuscitation from us. So our first and foremost duty is to identify, as you rightly put it up, which are the babies who require a resuscitation, who are the babies who don't require a resuscitation. So
Yes,
for
sir.
that, we are usually asked these three questions. Is the baby born prematurely or is it born at the time of full maturity, at full term? Second question is the baby immediately crying and breathing well after delivery, or is it having some difficulty in breathing? Third question is the baby having a good muscle tone by moving its, flexing its limbs and hands, whether it is having a normal muscle tone or a limp, reduced muscle tone.
Yes.
Earlier algorithm or this the so-called guidelines, they were including another point also, whether the mother had any evidence of infection like amniotic infection or the vaginal tract infection, or the amniotic fluid, was it clear or meconium stained, was also included in the earlier 2010 algorithms, but that has been
Okay,
now
sir.
removed. So another point you have to add to this answer is what are all the changes or the advancements or the alterations done in the guidelines periodically. So there was one
Okay, sir.
guideline in 2010, then another one 2015, and the recent latest one is 2021.
20.
So
Yes.
20 and 21 European guidelines
Okay.
also has come.
Okay.
So
Okay.
you have some subtle changes going on in all these things. That also has to be brought out. Okay.
Okay, sir.
And
Yes, sir.
all the other points you have beautifully mentioned. And finally, you must also mention about when to stop or make a decision to not to continue with the resuscitation, which are all the babies who cannot be salvaged, or
Yes, sir.
whether you should not attempt at all. It is withholding the resuscitation or discontinuing the resuscitation. That is a very important step that has to be, because you cannot be endlessly going on doing the resuscitation.
Yes, sir.
And for this point, you should have an anticipated, as soon as the first step you should go, where you ask whether the baby is a full-term baby or whether it is crying immediately or not, whether the muscle tone is there. Before that, you must be able to anticipate that the child born may have a need for neonatal resuscitation. So there are
Okay, sir.
factors with which we can assess whether the child which is going to be delivered by the mother, will it require a new resuscitation? For example, a prolonged labor, or a mother who has been administered opioid 4 hours prior to delivery. You naturally expect the baby to have the effect of opioid with a respiratory depression
Yes.
or some infection. Like that, there are parent, or the child is intrauterine growth retardation child. Is it a case of polyhydramnios or oligohydramnios? All these things in the mother and the fetus, they all may indicate that the child, when it is born, may require a resuscitation. So anticipating the resuscitation is very important from these factors. And from then on, you go for all the steps in the resuscitation. And then you finally decide whether to continue the resuscitation or not to resuscitate. For example, if the baby is born as an anencephalic baby and it is not breathing well, but there is a heartbeat, there is no point in resuscitating the
Yes, sir.
baby at all. You will be landing up with only a child which will be completely neurologically defunct, and it will be a burden on the parents. So
Yes, sir.
withholding the resuscitation also is an important criteria which you have to decide about. Okay.
Okay.
So
Okay, sir.
very good. You have done a wonderful job. I will just show
Thank you, sir.
some Kamachi. Can I share?
Yes, please, sir. Yes, please, sir.
So are able to see?
Yes, sir.
Okay. So neonatal resuscitation can be, these are the questions that you have to first ask. What is neonatal resuscitation? Then you have to assess the baby at the birth of time of birth. Then identify the babies which require resuscitation. What are all the initial steps in the resuscitation? Then the resuscitation consists of pulmonary resuscitation and vascular resuscitation. Another important difference you will find between a regular adult or other resuscitation and a neonatal resuscitation is we always start with the pulmonary resuscitation. Unlike an adult, nowadays we talk of colds, compression only life support, where we start with the cardiac compression. But in the neonatal resuscitation, please remember, if you saturate the respiratory function, heart will automatically pick up. So you don't go for cardiac compression first. You always try to saturate the pulmonary deficiency, then heart will automatically pick up. If after correcting the pulmonary deficiency, if the heart is not picking up, then only you have to go for resuscitation of the heart. So that is a very important difference between an adult resuscitation and a neonatal resuscitation. And when to terminate the resuscitation. These are all the headings under which we have to write the answer for that. So the neonatal resuscitation is a series of actions used to improve the newborn babies who have difficulty in making the physiological transmission from intrauterine to extrauterine life. So those babies who are not able to adapt to the extrauterine life, they are the ones who require that. So quickly you have to assess the newborn. It's all time restricted activities. So you have to complete everything within 1 minute's time. So very, very important. You can't be wasting time on assessment and then taking your next step. So if the term baby, that you will know even before the baby is delivered by the asking the physician whether the mother is delivering a term or not. This is very easy to find out. And after birth, these are the two things we have to find out, whether the child is crying immediately or having a good muscle tone. If all the three questions are yes, it doesn't require any resuscitation. So you can just take care it as a normal baby. Whereas if the answer is no for any of that, infant should be receive one or more of the following actions. Initially, that is, you can also write this answer as ABC survey, airway, breathing, circulation. And then initial steps of stabilization, ventilation, chest compression, administration of volume, epinephrine and volume expansion. These are the four important things that we are finally going to do. Then coming to the next thing, this is the golden minute, 60 seconds of initial steps, re-evaluating and beginning ventilation if required is the very important time we have to remember. Decision to progress beyond initial steps is determined by simultaneous assessment of respiration, heart rate. These are the two things which we take care of. Once positive pressure ventilation or supplementary oxygen administration has been started, simultaneously evaluate the heart rate, respiration, and state of oxygenation. The most sensitive indicator of a successful response is return of heart rate to normal. This is the best indicator to show that your resuscitation is going in the right direction. So mostly the children will have a bradycardia. If the heart rate goes up to beyond 120, that means you are doing a wonderful job in resuscitating the baby. Once it is remaining lower than 100, that means your resuscitation is lacking somewhere. And resuscitation equipments, what you need are the resuscitation bed or overhead warmer, towel, stethoscope, pulse oximeter, and airway management suction device, suction catheter, bulb syringe, laryngoscope. You must have the lowest, smallest size blades, 0 and 00, and ET tube, 2.5, 3, 3.5. ETCO2 detector, and nowadays they recommend LMA. LMA was introduced as an alternate airway equipment only in 2015. 2010 it was not there. So such small changes have been done. And then breathing support, either a face mask, positive pressure device, oxygen gas feeding tube. Circulation support, you have to have umbilical vein catheter and other IV cannulae, and drugs and fluids, adrenaline and normal saline blood. These are all the things that we require. So these all should be checked and kept ready in case you anticipate that the baby born may require a resuscitation. So all the neonatal resuscitation equipment should be kept ready before you deliver a child where you may anticipate resuscitation requirement. So these are all the pictures of those equipments which are required: radiant warmer, oxygen source, anesthesia, you have a near resuscitator. The equipment name is resuscitator. It has got an automatic airway pressure venting valve so that you don't blow out the lungs and cause damage. And it has got a pop-off valve of more than 250 ml, suction infant feeding tube, low pressure suction bulb, stethoscope, laryngoscope, ET tubes. Of course, this is a wrong picture with a cuff tube. It's there. You don't use a cuff tube. It is only a plain. And transport incubator and ETCO2 monitor, which can be attached directly to the tube and found out. Now, this is the 2010 American Heart Association algorithm for newborn. So these are the three questions that we asked, whether it's a term gestation, and you can see it is the time bound. So within 30 seconds, you have to do all these things and take a decision. So if the heart rate is below 100, gasping or apneic, these are the two criteria. First, start PPV. Don't go for any cardiac compression. So positive pressure ventilation, SpO2 monitoring. If the heart rate is still 100 or below, then see whether you are correctly ventilating. That is the second step. So first step to initiate ventilation. Second step is to check and correct the ventilation. And if the heart rate is continuing to go down below 60, then consider intubation and proper ventilation. So three steps are given only for ventilation. First step is for proper positive pressure ventilation without intubation. Second one is correcting, clearing the secretions and other things. Third one is going for advanced ventilatory management. So by doing these three steps, you expect the heart rate to come back to normal. If still the heart rate is not coming back to normal and it is still low, then only you go for IV epinephrine and correct hypovolemia or pneumothorax and all those things. And then once the heart rate picks up, you have to take care of the post-resuscitation also. And the SpO2 will not be 100% in a newborn. You have to remember that. At 1 minute after birth, it will be 60 to 65. At 2 minutes, it will be 65 to 70. Only at the 10th minute, it will come to 85 to 90. So early low SpO2, you need not worry about. So after about 3 minutes or 4 minutes, if it is still less than 50, then you have to worry. Otherwise, normally it takes a little time, up to 10 minutes to become normal. That is a very important knowledge that you should have. Then in the 2015 update, what they did was, you can see there is a small change here. They check the chest movement, ET and laryngeal mask. So here it was an intubation. Whereas in 2015, they said laryngeal mask can be introduced if needed for improving the ventilation. That is the only change. And only go for intubation if it is not already done when the heart rate is below 60. Okay? Otherwise, all the other things are all the same. So the only change that has been incorporated in 2015 update is the introduction of laryngeal mask airway to the algorithm. Then in the newborns who do not require resuscitation, delaying the cord clamping, all those points you said will reduce the anemia. So more blood will be given to the baby. And no type of routine suctioning. Previously, they were advocating in 2010 and all, you must routinely suction the nose, suction the mouth, and then take out all the amniotic fluid or whatever the child is swallowing. That is not at all recommended now. And unless only meconium stained, you have to take care of that. And heart rate should be monitored by ECG. This is the next improvement or modification that earlier it was only by pulse oximeter or by auscultation that we were monitoring the heart rate. Nowadays, they say that in the 2021, they say as early as possible, put an ECG monitor to monitor the heart rate. Positive pressure ventilation should be started in newborns who are gasping and apneic with a heart rate below 100 per minute within 60 seconds of life. That time interval, that is why it is called the golden minute. So do not delay. And this is the latest 2021 update you can see here. So here what you do is you have to do an antenatal assessment and check supplies and keep all the allocated. This was not there earlier. So nowadays we know that we have to anticipate in some babies a need for neonatal resuscitation. So if you need that, you keep yourself equipped, and always one person who is trained in neonatal resuscitation should be available in all deliveries. And delivery time, again, the same 3 questions, and then considered delayed cord clamping. This is also introduced in 2021. And of course, we are going to place the baby under a heat source and positioning the head and drying the baby and repositioning the head. These are all small modifications. And then all the other steps are going to be the same until you go on to use the drugs and other things. And here, once the baby doesn't require any resuscitation, skin to skin contact with the mother should be established. This was not there in the earlier ones. Now it has been introduced. And here again, the SpO2, they start from the 3rd minute. You don't worry about the first 2 minutes because it is around to be 60, 65. You go for the 3rd minute also only, and then try to late preterm infants may manage as a term infant if breathing and muscle tones are adequate. So this is how you, even if they are born slightly premature, that is say about 36 or 38 weeks, but they are breathing and their muscle tone is normal, treat them like a normal full-term infant. There is no need for any special attention. Now, anticipation of resuscitation is very important. Every birth should be attended by one person who is trained. Additional personnel area if they think it may be a complicated resuscitation. Equipment checklist and role should be briefed, and everybody should be available. Care of the well-born, early skin-to-skin contact is very important. So this is how the baby is made to lie on the mother's chest with the contact. So the baby also feels reassured and mother is also happy. And routine suctioning should be avoided. Of whether oral or nasal is not recommended. This was there in the earlier 2010 recommendations. Now this is they have found out that it causes bradycardia in the baby. So routine suctioning is not needed if the baby is crying vigorously and breathing well. So this should be avoided. Okay. And delaying cord clamping for more than 30 seconds is reasonable for term and infants who do not require resuscitation. Delaying clamping increases hematocrit and iron levels without increasing the rates for phototherapy for hyperbilirubinemia and neonatal intensive care and mortality. So slightly delaying for 30 seconds the cord clamping helps. Then milking the clamp should not be done. That is another thing that they say. Cord milking should be avoided. So previously, all the senior nurses, they used to squeeze the ET tube and then try to clamp it, thinking that they are pushing more blood. That is not recommended now. And then initial resuscitative actions, preterm and term newborns without good muscle tone or without breathing and crying should be brought to the radiant warmer for resuscitation. So try to do it under the warm lights. Don't do it on the just a simple trolley or something like that. And newborn temperature should be maintained between 36.5 and 37.5. And morbidity increases with hypothermia, especially in preterm and low birth weight patients. And according to the recommendation, suction is only necessary if the airway appears obstructed by fluid. Otherwise, no regular suctioning. For non-vigorous newborns and meconium stained fluid, endotracheal suctioning is indicated only if obstruction limits positive pressure ventilation. So if the baby has meconium aspiration, then you can put an endotracheal tube and suction it. Tactile stimulation is reasonable. So this is how you do the tactile stimulation. Earlier days, all of you would have seen they used to hold the baby upside down and slap on the back and the buttock. That is all not recommended now. You have to just squeeze the legs and then rub the feet. That is all the tactile stimulation that you have to do. And ECG should be applied as early as possible rather than depending on the pulse oximetry. So you can put the ECG electrodes like this to monitor the heart rate. Nowadays, we have got wireless ECG electrodes. So this is a picture of where you can just put the electrode and it picks up. Nowadays, we are going in for what is called contactless monitoring. especially after the COVID. It has become a very important topic to do what is called contactless monitoring. I don't know how many of you have read about it. I learned it only today. And ventilation and oxygen support. So within the first 6 minutes, 60 seconds, that is first minute, you should try to do all that and get the heart rate above 100 and positive pressure 40 to 60 inflations with a maximum pressure of 30 centimeters of water. And in fact, the resuscitator or the ambu bag you use for the babies, usually it has a pressure relief valve at 25 centimeters so that you don't damage the lungs. And you can use PEEP up to 5 centimeters of water. So this is how you do the resuscitation. In preterm infants younger than 30 weeks of gestation, positive pressure instead of intubation can reduce the bronchopulmonary problems. And newborns at 35 weeks of gestation or later, you start with only 21% oxygen. So born before 35 weeks, oxygen concentration above 50% are no more effective than lower concentration. So because of the fear of eye problem that can happen, the so-called, what is that?
Retinopathy of premature.
Prematurity. So in premature baby, don't use the 100% higher concentration. 21 to 30% should be sufficient. And you can see the saturation is only 88%, but that is acceptable. And then coming to the chest compression, if the heart rate remains below 60, despite 30 seconds of adequate positive pressure ventilation. So they always give first priority to proper ventilation. And if in spite of your adequate ventilation, if the heartbeat is still low, chest compression should be initiated by two-thumb technique at the rate of 3:1 compression to ventilation ratio. So these are the two older techniques which we used to do. Encircling the chest and then using the thumb for resuscitation, or supporting the back with the one hand and then using two fingers from above, the index and the mid finger, for pressing the lower part of the sternum. These were the two things. This is not recommended anymore. Now they recommend only this technique, encircling technique. And if you are a single person who has to do both the ventilation and resuscitation of the, compression of the heart, then this is recommended. You can hold the mask to the face and continue to ambu the baby. At the same time, use your fingers for compressing the heart. So this is a single person resuscitation. And before chest compression, you should make sure that the ventilation is optimized properly. This is a newer method of, this is another technique of this new thumb, two thumb method. Here you are keeping the thumb side by side, whereas here you are keeping it one over another. Now there is a latest technique, newer technique called the newborn chest compression technique, where you keep both the thumbs side by side with your fist closed, and the thumb should be at 90 degrees, and you start compressing. This is the newest and latest new technique. So developed by Mereka et al. The new two thumb technique consists in directing two thumbs at the angle of 90 degrees to the chest while closing the fingers of both hands in a fist. So the hand is, these fingers are exactly at 90 degrees to the lower part, lower end of the sternum, and you just give compression like this on a flat board with support on the baby. Now, European guidelines 2021, the summary is management of umbilical cord, about clamping, what we had told earlier. Infants born through meconium stained liquor, non-vigorous infants only, you recommend aspiration. Otherwise, if the baby is nicely crying and breathing in spite of meconium aspiration or stained liquor, you don't have to do anything. You just have to observe the baby. And use a laryngeal mask instead of intubation is also, if ventilation with face mask is unsuccessful, or if you are not able to intubate also, you can use a laryngeal mask as an alternative means of establishing airway. But the infant should be more than 34 weeks. That is the only caution that they say, gestation, or it should be about 2 kgs weight. although some devices have been used in infants up to 1.5 kg. And the inflation pressure maximum should be 25 to 30, and especially in preterm babies. And air oxygen should be the not 100% oxygen is not recommended, 21 to 30%. And chest compressions are required, and inspired oxygen concentration can be there for 100%, can be there for a very short period, not for long periods. And vascular access should be, usually you choose the umbilical vein over other areas. Adrenaline, glucose, and the observation of prognosis are very important. And so this is the vascular access. Normally we do like a peripheral vascular access in the wrist. This is the scalp vein where you can cannulate if you are, and these are the umbilical artery, umbilical vein cannulation. There are two arteries and the vein. So this is how the umbilical vein is cannulated. And this is the intraosseous method of infusion. You have special needles for that, which is a 15 mm needle or a 25 mm needle, and you can use this. So these are all the equipment needed for intraosseous. So instead of trying to force with your fingers, you have got a sort of gun which you can just press and press this button. It will go through the bone and establish the airway. And you have got all the IV tubings which can be connected to that. Or very rarely you can go for a central vein access also. So it can be either a tunneled or an untunneled if long-term resuscitation or supplementations are needed. Then factors to indicate the need for neonatal resuscitation, you can classify them into antepartum and intrapartum. Antepartum, fetal causes are either an IUGR or a premature baby, multiple pregnancies, or serious congenital anomalies are detected by antenatal checkup, oligo or polyhydramnios. These are all the fetal causes where you anticipate that the baby may require a resuscitation. Coming to the maternal causes, infection, gestation diabetes, pregnancy-induced hypertension, preeclampsia, obesity, short stature, preterm lack of antenatal steroids, all these things may indicate a need for neonatal resuscitation. Or intrapartum factors, evidence of fetal compromise, where the non-assuring cardiotocograph, where the decelerations are very frequent, or a meconium stained amniotic fluid, delivery of a breech or a forceps or vacuum delivery, significant bleeding, C-section before 39 weeks, emergency C-section, general anesthesia. All these things can result in the need for a neonatal resuscitation. So this is the picture to show an IUGR. This is the same baby born at the same time. This one is a retarded growth. This one is a normal growth. And this is how in the twins, one baby may be normal, other may be retarded. And this is the baby with a normal, what is that? All the caseous vernicose or something like that. The normal looking baby. This is the meconium stained baby with a darker color smearing all over the body. And the top messages are delaying the cord, especially in normal babies. Effective thermal care is very important by dry wrapping and stimulation. Assess breathing and heart rate. Faster heart rate indicates adequate oxygenation. So this is a very important point. Simple steps to support airway and breathing will manage most of the problems. There is no need for any heroic intubation or anything. Chest compressions only once effective ventilation is established. This is a point repeatedly you have to remember. You have to start chest compression only after establishing effective ventilation. And if still the heart rate remains low only, you have to go for chest compression. Then classification according to initial assessment. Earlier they were using UPGAR score for 1 minute UPGAR, 5 minutes UPGAR, 10-minute UPGAR were used for assessing the infant at birth at 5 minutes and 10 minutes to decide whether there will be permanent neurological damage or not. All that is not now included in the algorithm at all. But the two components of ABGAR, the respiratory and heart rate are taken into, and the tone, they are taken into account. So if an initial assessment of the tone, breathing, heart rate help determine the need for resuscitation. So if there is a good breathing, good heart rate, good tone, it's a normal baby, just leave it off. Then if you are just giving the respiratory support and then there is a good tone, vigorous breathing, then that is a satisfactory transition from the fetal life to the extrauterine life. When there is a reduced tone, when there is inadequate breathing and heart rate low, that means the patient is not got into the transition from uterine to extrauterine life. That is an incomplete transition. And if the patient is very floppy or pale and breathing is not there or it is apneic and heart rate is less than 60 or undetectable, it is a very, very poor transition. So this is the baby which requires the maximum support. This will be easily salvageable by good ventilation. So this is how you assess the transition. And if there is an airway obstruction, you have to just normally correctly position the child. That itself is important enough to maintain the air entry. So it should be neither too flexed nor extended. It should be in the neutral position. And the lifting the jaw sometimes is more than enough than doing anything else. And oropharyngeal airway may be sometimes needed, or a nasopharyngeal airway also can be considered. So how to decide the length of the oropharyngeal airway is from the angle of the mouth to the angle of the mandible. Whereas for nasopharyngeal, it is from the nares to the tragus. So these are the two small differences between these two methods of assessing the airway. And there are machines available nowadays which take away the fatigue of your hand trying to oxygenate the patient. Neopuff positive pressure device is there. So you have a patient circuit, you have all the gadgets, so it can deliver oxygen and the gas mixture, air mixture. This is the delivery outlet to the patient. And there are airway pressure gauge to safeguard that you don't overinflate and cause too much of pressure. So this will automatically show the pressure and release the pressure also if there is a higher pressure. So the maximum in gas inlet, outlet, maximum pressure release knob, positive pressure knob, all these things are there. Can you just identify what is this equipment? Now that it is attached to the endotracheal tube, can anyone guess what it is used for? I told you earlier how to remove meconium. This is called a meconium aspirator. Okay, so you can attach
Without
this.
applying pressure.
Yeah, you can just
Just
suction
pull up.
it and then remove it. So this is the meconium aspirator which can be used after intubating the baby. Then what are all the drugs you have to use for active resuscitation? When the heart rate is not picking up, you go for adrenaline. All the dosage was described nicely by Sanjeev Raju, 10 to 30 micrograms. So it is better to say in micrograms rather in milligrams. Okay, so that because it's a very small dose. And intratracheally also, if the patient is intubated, you can give. And then you have to always watch for glucose levels during resuscitation. So they should not be hypoglycemic. So you can use 10% glucose, and rarely you can use sodium bicarbonate if it is a prolonged resuscitation, not in short resuscitations. You can give 1 to 2 millimole per kg. And in situations of persistent apnea, and there is a history of administration of opioids, you can give naloxone. So if there is a history of mother receiving opioids 4 hours before delivery, you can give 200 micrograms of naloxone intramuscular, okay, not intravenous. And Volume replacement is the last thing in the drug resuscitation, 10 ml per kg or O negative blood. And post-resuscitation care, you have to take care of all the, assess the neurological recovery is very, very important. So that, and also post-resuscitation glucose level monitoring is very important. Temperature care should be done properly. And you can use therapeutic hypothermia depending upon but there should be evidence to justify the treatment. It's very, very important. And the hot blood gases and neurological examination have to be done, and the parent should be informed about it. So when monitoring and treatment consider inappropriate application should be avoided without concern of the diagnosis of hypoxic ischemic encephalopathy. If this is suspected, after proper documentation and information to the parents, you can try therapeutic hypothermia. And then prognosis. Ensure clinical records allow accurate retrospective time-based evaluation. Very, very important of the clinical state of the infant. Especially nowadays, you know, many babies are very precious babies. And mothers go for infertility treatment and come for delivery at a very, as an elderly preemie, even at the age of 38, 40. And the baby is very precious. So in such events, it's very, very important that we record all the resuscitative steps and the progress of that in a very proper way, and communicate with the patient. Whenever there is any intervention is needed or anticipated, you must tell the parents what you are going to do and what do you expect out of that, what should be the result of that. Discuss the options and the potential need and magnitude of resuscitation before delivery and after delivery. Record carefully all the discussions and decisions in the mother's notes. When to discontinue resuscitation, failure to achieve return of spontaneous circulation in newborn infants after 10 to 20 minutes of intensive resuscitation is associated with high risk of mortality and high risk of severe neurodevelopmental impairment. So this is a very important point. You may resuscitate a baby after even 1 hour, but if the baby develops a neurological issue, encephalopathy, it will be a lifelong burden for the parents. They will have to support the child with all the deformities, and milestones will be delayed. So you have to take a proper decision. There is no evidence that any specific duration of resuscitation universally predicts mortality. This is the only dilemma where we will be put into. We don't know when to stop. Severe neurodevelopmental impairment may happen. So this is a very tricky situation we have to hold. When will you withhold resuscitation? This is the earlier one was discontinuing after starting the resuscitation. Whereas when will you not do the resuscitation at all? That is in situation where there is extremely high predicted mortality or severe morbidity in surviving infants. As I told you earlier, anencephaly child born with a beating heart and with some good respiration. Apneic spells. You don't do a very vigorous resuscitation. So withholding resuscitation may be reasonable, particularly when there has been opportunity for prior discussion. So if you know by ultrasound there is an anencephaly or a very severe congenital malformation, then extreme prematurity or bilateral renal agenesis, which are all can be diagnosed antenatally. So withholding resuscitation or discontinuing the life-sustaining treatment following resuscitation may be ethically accepted. So it can be, it is not unethical, you don't do that. And clinicians should not be hesitant to withdraw treatment when it would not be in the best interest of the infant. This is a very, very important statement. So you should not continue the resuscitation if it is going to harm the baby lifelong. So successful resuscitation depends on this ability. So you have to, you are like an octopus. Time is very, very short. So you have to keep a watch on the time. You have to take care of the trachea, stabilize the head, monitor the heart rate, provide suction if necessary, and then bag the baby, check the tube placement, provide oxygen, tape the tube. So already all of us know that anesthetists are multifaceted or multitasking people. So we should bring our best by doing all these things to have a successful resuscitation. Okay.
Okay.
That's all. Thank you.
Thank you, sir. Thank you for a very wonderful, extensive coverage of neonatal resuscitation, sir. And I hope it will be a eye opener for all our young students.
Okay.
And in the coming days, the challenges to be faced by our young team will be really, really very much demanding in the emerging scenario of patients' expectation and advanced medical sciences. You have rightly pointed out the newer developments in the equipment, gadgets available, and the importance of documentation also, sir. Thank you very much, sir. Any doubts from the students? If no doubts, sir, can we decide about next week's case, sir?
I will decide that tomorrow.
Okay, sir. Okay.
Okay.
Yes,
We
That's
could do something on exit procedures, sir. Now that I was listening to this resuscitation completely,
okay.
I think they can have one person can probably talk on anesthesia for exit procedures.
Yeah, you are the authority on that. I think you are the only one who has done that.
Sir, somebody can,
You can-
these
yeah,
boys,
yeah,
students can do it.
That can be a topic for discussion, and
One short topic, sir. One
yeah,
short.
you will be in charge of that fully.
Okay, okay, sir. Okay, sir.
yes, sir.
Okay.
Thank you, madam. Thank you.
Thank you. Thank
So
you.
next week, we'll give, this is repeatedly asked theory questions. So we can have theory question presentation of exit procedure.
Okay. Right.
Okay. Thank you, sir. Thank you, madam. Thank you, dear students. With all your
Thank you, sir.
permission, can I sign off this meeting, sir?
Thank you. Thank you.
Okay.
So thank you very much, sir.
Thank you. Thank you,
Thank
Rohit.
you.